All right, so while we wait for the IT team to complete their arrangements, we'll take a short round of self-introductions, not details, just your name, so that I'm sure by the time we are done, the IT who are joining virtually can also have the chance to participate. So I'll start from my immediate right. Thank you.
Yeah, so I'm Dr. Anthony Zunodondem, Fred N. Binker School of Public Health, University of Health and Allied Sciences.
I'm Seth Kwabnamponsa, the Dean of the School of Basic and Environmental Sciences. Thank you.
I'm Nuoza Kube, Head Department of Environment and Public Health, University of Environment and Sustainable Development, Somanya.
I'm Gifty Ampofo, the Head of Department of Community Health in the School of Medicine, UHAS.
Hello, good morning, everyone. I'm Fred Osesapon, the immunization focal point in the WHO Country Office for Ghana. Thank you.
Good morning. I'm Dr. Aziato Berima, Technical Officer for Health Financing and Human Resources for Health, WHO Ghana.
Good morning. I'm Alexander Ansamenu. I'm the Director of the Institute of Health Research for the University of Health and Allied Sciences. Welcome.
Good morning. I'm Samuel Ezianbedu, Acting Director, R&D at the National Vaccine Institute. Thank you.
Good morning. I'm Dr. Mavis Pearl Kwabla from the University of Health and Allied Sciences. I'm with the Fred Newton Binker School of Public Health in the Department of Epidemiology and Biostatistics. Thank you.
My name is Gideon Chidiodu with the Fred N. Binker School of Public Health, UHAS.
I am Livingston Assem, also with the Fred Newton Binker School of Public Health.
And I'm Mark Kwame Ananga, Fred Newton Binker School of Public Health, UHAS.
I am Jonathan Jato, School of Pharmacy, UHAS.
Hi, I'm Irabna Gami, School of Pharmacy, UHAS.
I'm Araba Hudson Yamiaye, School of Pharmacy, UHAS.
Martin Norwich, my name. I'm with UHAS and Fred N. Binker School of Public Health.
Good morning. I'm Yete Enwame with the Kwame Nkrumah University of Science and Technology, School of Public Health. I'm the head of department with the EP Biostat Department, and I'm also the Vice Dean of the school. Thank you.
Hello, good morning. I'm Gilbert Abiro. I'm with the School of Public Health, University for Development Studies. I'm the Vice Dean of the School of Public Health.
Good morning to you all. My name is Maxwell Dalaba, the Director for Non-Communicable Disease Research at the University of Health and Allied Sciences. I'm also a health economist. Thank you.
Good morning. My name is Abdullah Abubakari, also from School of Public Health, University for Development Studies.
Good morning. I'm Cornelius Dodu with the School of Pharmacy, University of Health and Allied Sciences. Thank you.
Thank you very much. So that's the incoming Dean, School of Pharmacy. My name is Kwame Ohinibuabin, outgoing Dean, School of Pharmacy, UHAS, and the member of the Steering Committee, Health Technology Assessment.
I'm Vivian Taki, School of Nursing and Midwifery, UHAS.
I'm Eduje Yorangbemu, School of Public Health, UHAS.
I'm Fidelis Anumu, Research Operations Office, Institute of Health Research, UHAS.
I'm Augustina Fra, School of Public Health, UHAS.
I'm Maoli Kushito, School of Public Health, UHAS.
I am Georgina Ohimin, School of Public Health, UHAS.
I am Blessed Adiza Amana, School of Public Health, UHAS.
And I'm Lois Humeyatuzipokobaba, School of Public Health, UHAS.
I'm Gifty Emefadopo, School of Public Health, UHAS.
Okay, I'm Boafo Efriye Diana, School of Public Health, UHAS.
I'm Selina Tayoko, School of Public Health, UHAS.
I'm Felix Teko, Fred Newton, School of Public Health, UHAS.
And I am Gladys Damalin with Hope for Future Generations.
Okay, I'm Joshua Odinakachi, Fred Newton Binker School of Public Health.
Thank you very much. The ICT technicalities have been sorted out, so we'll zoom in to the program.
All right, that was beautiful. Let's give a hand of applause for ourselves for that quick round of introduction. All right, thank you. You are all welcome once again. So commence by taking a welcome address from the host, who is the Vice Chancellor of the University of Health and Allied Sciences. Let's put our hands together for Professor Lydia Aziato. Thank you.
Thank you very much, and a very, very good morning to all of us, and a warm welcome to the Volta region, to Ho, which is the cleanest city in the country, the freshest air, the highest level of oxygen, and the most beautiful university in Ghana, UHAS. Welcome, Nyawe Zolo. It's a pleasure to be here this morning. I remember we're in the Anudo Auditorium where we discussed emergency preparedness, I remember. And today we are here to talk about financing primary healthcare. I know that this area is dear to the hearts of our President John Dramani Mahama. And I'm happy to see that NHIS, am I right, is here. I'm happy to see that MVI is here. And of course, UHAS is here. KNUSC is here, UDS is here. UG is supposed to be here, but because some of us were imported from UG, yeah, UG is here. Somenya is here, and WHO is even here. And so I'm sure that our discussion will be very, very, very productive. So the discussion is not about the essence of primary healthcare. All of us here know that primary healthcare is important. It is important for us to assess health wherever we are. It is important to prevent the disease or stay healthy. It is important that no matter where we are in the country, there's a timely access to interventions before it becomes too late. So primary healthcare is not about extending healthcare to the rural areas, no. It's about all of us, no matter where we are. We assess health, it is affordable. We are able to do the prevention aspects of disease. We are able to integrate all aspects of care that will make us all healthy.
Recording in progress.
That is my understanding of primary healthcare. So we all underscore that it's important. That is important also demands some money or some resources. And this discussion today, my expectation is that all the experts on the table will share how do we fund this sustainably, not just because our so resources are provided, a new government comes and it's not the priority and it dies down. No. How do we keep all of us healthy? How do we make sure that all of us, we have the necessary health care at our doorsteps? So I am expecting that there will be a communique or some write-up that will be published or shared to the relevant bodies to see how do we move forward. Over the years, we've had a lot of talk shop, but I believe in action shop. So the academics are supposed to and bring the innovation that will say, we didn't think about this aspect of funding. We didn't think about the aspect of funding. How do we get it added to what we have already? Just use the normal existing funding streams. It will run out, or we are robbing Peter to pay Paul. So instead of doing something that we are supposed to use the money, become a priority, we dive and do ABC, and once the person moving it is not there, it dies down. So here, I'm expecting that the experts or the experts, in quotes, would, tell us something that we didn't think about. It didn't occur to us, so that it's to the station plan of how do we finance primary healthcare, which is very, very important. My other suggestion is that we decouple politics from the suggestions of financing. Sometimes we are quick to lean to some area because it is a manifesto or a political promise. But with your expertise, with your scientific knowledge, with your experience, even if you are not aligned to that political orientation, what can work? That is what my expectation is for this group. Because the best brains are here from all these institutions that we have mentioned. Put politics, what can work, share with Ghana so that when it is implemented, we can all benefit from it. I also want to say that because we are streaming live, we are, sometimes when you're passionate about something, if you don't take care, you veer off. So we want it to be an academic discourse, a solution discourse, not painting something black when it doesn't need that black paint. I just want to say this because this is an academic environment, and therefore we want to stay on the road as much as possible and not veer off. The other thing that I want to say is that we want this to be an annual event, an event that every year we bring best brains together. And I'm also happy about the collaboration and partnership. It's not just a UHAS event, but an event that shows how we want to work with other institutions or bodies on an issue, okay, on an issue. So I pray that it becomes an annual event, that one year in the calendar of an academic season, we bring our partners, friends, best brains together to discuss on an issue of national importance. Before I leave the platform or the mic, is to also say, as a university, we are only training health professionals. We are in the health space. So if we don't lead this, if we don't bring people together to discuss a health issue of national importance, then we have missed our core. So a part of our mandate to train is also to contribute to relevant national issues that is of importance to all of us Ghanaians. And so this symposium is part of our mandate. It's part of our mandate. And I want to thank Hope for future generations. I like even the name of the organization, Hope for Future Generations. One of the things that makes me like the name is that it is only hope that keeps us alive. So if we don't discuss to prepare the way for the future generation, then there's no hope. And I want to thank them very much for the continued collaboration with the University of Health and Life Sciences. We know that the Alfred Newton Binker School of Public Health is at Hohoe, but we always have the program at home. I also like it because it shows that whether we are at Ho or we are at Hohoe, we are still one, we are still UHAS. So the Binker School faculty and students, welcome to the headquarters of the University of Health and Allied Sciences. I'm always happy when I see you here. And the last thing I want to, yeah, you can clap for yourself for coming all the way. The last thing I want to also say is that tomorrow is unknown. Tomorrow is unknown. And so we can only make the best preparations for tomorrow. And if primary health care is for tomorrow, then it is good that we prepare how we finance the tomorrow today. Thank you very much.
Thank you, VC. Please, let's give her one round of applause again. That was beautiful. Since we are only living on hope, we would want to invite the Executive Director for Hope for Future Generations, Cecilia Senu, to give us her welcome address. Let's give it up for her.
Thank you very much. I will stand on Prof's protocol to say good morning, and I will deliver my speech. I have a lineup of professors and many people that I'm supposed to be mentioning, but I will stand on all protocols. And also to say thank you for making time. It is my distinct honor to welcome you to this critical engagement forum on the theme, Advancing Sustainable Financing for Primary Healthcare in Ghana. From academic research to policy making, Ghana's gains in child survival and disease prevention through the expanded program on immunization are very remarkable. Yet, as we transition to middle income status, the financing landscape is changing. External support for immunization and health in general is declining, while our obligations under Gavi co-financing are increasing. ODA has decreased significantly. The country multi-year plan 2020 to 2024 estimated that Ghana needed $514 million for immunization, but only $266 million had been secured by the end of 2024. A revised national immunization strategy 2025 to 2029 is underway, but projections show the funding gap will widen unless domestic financing is scaled up. I mean, this is what the whole world is talking about. This forum is our call to take ownership of sustaining the gains we have made. With support from the Global Health Advocacy Incubator, Hope for Future Generation is driving advocacy for increased sustainable domestic resource mobilization and stronger accountability for results, especially for zero-dose children, and improved coverage of newly introduced vaccines. The role of academic institutions bring evidence we need. Through rigorous research, they generate credible data to inform policy and shape practice. And I will just add that this is very important and we need this at this important time. The symposium is designed to bridge research, policy, and implementation by bringing together scholars, policymakers, practitioners, and development partners to tackle key questions on sustainable financing for vaccines and other essential commodities. Today, you will hear keynote addresses from Prof. Lydia Aziato, Vice Chancellor, UHAS, Dr. Senanu Kwesi Jokoto, a Deputy CEO, NHIA, and a friend of civil society organizations in Ghana. We will also have presentations on innovative financing for primary healthcare and health commodity security, sustainable free primary healthcare in Ghana, immunization financing models, and health security, and lessons on UAC financing and other flagship programs for Ghana and from other countries. Our objectives, which Prof has already enumerated, by the end of today, we expect to provide a platform for academia to share research on sustainable financing, strengthen collaboration between academia, stakeholders on domestic mobilization, resource mobilization for PAC and immunization, including other healthcare programs.
Do you know the name of
Develop
your new
evidence-based
principal?
recommendations on successful health financing models from other contexts. Amplify academia's recommendations to the government through Symposium, communique for publication.
Sierra and Mainstone.
And Hope for Future Generation will work closely
So I'm
to
sure
ensure
they will
that
call
we
him
take
Mr.
this beyond
Mainstone.
Ghana. As Hope for Future Generation,
Mainstone.
a women-led, community-based organization, passionately marks 25 years of service and impact. We celebrate a journey that has reached communities across all 16 regions of Ghana and beyond Ghana, improving the lives of children, adolescents, women, and families. We have been the voice for the voiceless, partnering development partners at all levels to deliver our mission. This milestone reflects the strength of our partnerships with government institutions, the private sector, and academia. We could not have done it alone. In closing, I express our sincere appreciation to the various committees, stakeholders here today for your continued commitment to this cause. We appreciate it, and we hope, as Prof said, it will be annual programs that will continuously plan with you and implement with you. We thank you, and may our deliberations yield actionable outcomes. Thank you very much.
Madam Cecilia again as well. 25 years of community support, we appreciate that. So to continue, we want to invite Dr. Gideon Chedodu. Where is he? All right, so let's give it up for Dr. Gideon Chedodu to introduce the chairperson and all our invited guests for us today. Thank you.
I need a profile of Prof. Amuna. Ouch. All right, good morning to you all, and thank you for coming. And thank you to our Vice Chancellor and Cecilia Senu, my good friend. All right, so for the chairperson for this event is our own Professor Paul Amuna. And I'm looking for his profile. Let's give him a round of applause. So I'm looking everywhere for his profile to be able to read. Is that you? Okay, he's asking me to skip that for now. But he will be the chairperson for this event. So with a round of applause, let's invite him to give us. You want to come? Oh, I can bring it. So, okay.
Thank you very much. I am trying to emulate my Vice Chancellor. Let not the focus be on you. That's the important thing. I add my voice of welcome to all of you. and to reiterate the point that the Vice Chancellor made earlier on, that this is not our first meeting of this kind. Let me start by acknowledging the Vice Chancellor, Professor Lydia Aziato, our hostess. I also want to acknowledge the Deputy CEO of the National Health Insurance Agency, Dr. Jokoto. We have the Executive Director of Hope for the Future. We have WHO representative. We have colleagues from the National Vaccine Institute. And then we have colleagues from sister universities across the country. And we have our colleagues from the University of Health and Allied Sciences. I believe the media is here as well. And so I would like to thank you for covering this and supporting the cause. I am glad that we are meeting once again in Ho at the University of Health and Allied Sciences on this very important topic. And we have gathered here with experts from various areas who are going to be debating or talking on the subject. In her speech, the Executive Director of Hope outlined some of the key areas in terms of the fact that the nation is growing, and so resource mobilization to support healthcare is very important. Incidentally, Professor Yeti and myself were in the Gambia last week. And exactly on a Friday at exactly about this time, we were having a discussion about healthcare and healthcare financing in the Gambia. And one of the questions they asked us, we from Ghana, was, how do you fund your healthcare? And we learned something interesting about the way that they fund their healthcare. Healthcare is supposed to be free at the point of delivery. And they pay just about $100, which is just over $1 for when you go to the healthcare facility. And that is supposed to cover your consultation, your medications, and everything. But then there is a trick there, because when you look at the list of essential medicines, you know, they go for the very basic ones, and then the rest of it is out of pocket. We have that experience here, and so we shared with them briefly some of the efforts that are being made in this country. And today we are here to discuss particularly financing for primary health care. And as has already been alluded to, as a nation we have decided to embark upon a free primary health care strategy. It's been implemented. It is not partisan, and I want to just agree with the Vice Chancellor that it is about Ghana. So yeah, Oman year, Professor Boabin, I hope my stay in Obuasi I've learned one or two things there. So on this note, I thank you very much for asking me to chair this. I'm sure it's going to be very lively. There'll be a lot of discussion, and I'll come back at the end, but I will rather allow us to proceed with it. So thank you very much for the honor of asking me to chair this session. Thank you.
All right, thank you so much, Prof. Let's clap for our chairperson properly. Thank you. So we will be taking our first keynote address, and to introduce to you, I would spend a few minutes of your time to go through our speaker's profile. Dr. Senanu Jokoto is the Deputy Chief Executive Officer, Operations of the Ghana National Health Insurance Authority, where he provides strategic leadership for the operational implementation of Ghana's health financing reforms and advancement of universal health coverage, UHC. A seasoned public health expert, health system leader, healthcare innovator, Dr. Jokoto brings over a decade of experience in health sector leadership, policy implementation, health system strengthening, and service delivery transformation. Throughout his career, he has remained committed to expanding equitable access to quality healthcare, improving population health outcomes, and strengthening the resilience and efficiency of Ghana's healthcare system. Dr. Jokoto has distinguished himself through the successful design and implementation of transformative health initiatives that are delivery, operations performance, and health system responsiveness. His expertise spans public health, management health systems, governance, disease control, health financing, emergency strategic leadership, and organizational transformation. Prior to joining the NHIA, he served in several senior positions within the Ghana Health Service, including District Director of Health Services for Nkwanta South, Nkwanta North, and Home Municipality. Let's give it up for him. In these capacities, he led major interventions in disease prevention and control, health system strengthening, healthcare quality improvement, and population health management. Dr. Jokoto demonstrated exceptional leadership during public health emergencies, serving as a key coordinator of Ghana's COVID-19 response efforts in the regional level and incident commander for multiple disaster preparedness and emergency response interventions. His works contributed significantly to strengthening public health surveillance systems, emergency response coordination, and community resilience. Since his appointment as Deputy CEO of the National Health Insurance Authority in February 2025, Dr. Jokoto has played a central role in driving the NHIA's transformation agenda. He has provided leadership for the rollout of the key digital reform systems, supported the implementation of Ghana Free Primary Healthcare Initiative, strengthened strategic purchasing and provider engagement mechanisms, advanced operational efficiency, contributed to significant membership growth, and enhanced stakeholder collaborations across government, development partners, and the private sector. His work continues to support Ghana's ambition of achieving universal health coverage through a sustainable, equitable, and people-centered health financing systems. Academically, Dr. Jokoto possesses a strong interdisciplinary background that combines medicine, public health, business administration, and health system leadership. He holds a Master of Public Health MPH and a Master of Business Administration MBA from the University of Ghana, equipping him with a multiple, unique blend of technical, managerial, and strategic expertise in healthcare delivery and health system management. He is a fellow of the prestigious Dr. Lee Jong-woo Fellowship Program 2024 Epidemiology Cohort at Yonsei University of the Republic of Korea, where he enhanced his competence in epidemiology, disease surveillance, public health preparedness, and evidence-based decisions. Dr. Jokoto is also an alumnus of the Leadership Management and Governance Program at the Sotmo University Business School in 2024, a cohort member, a highly competitive executive leadership program supported by the Bill and Melinda Gates Foundation. Through this program, he further strengthened his capabilities in strategic leadership, organizational transformation, governance, change management, and health system strengthening. His academic and professional development reflects a lifelong commitment to excellence, innovation, and advancement of sustainable health systems that improve health outcomes and access to quality health care. As a keynote speaker, Dr. Jokoto brings a unique blend of policy implementation operational experience that is highly relevant to Ghana's ongoing efforts to strengthen primary healthcare systems, achieve full domestic financing of essential health programs. On this note, ladies and gentlemen, help me welcome Dr. Senanu Kwesi Jokoto, our keynote speaker for the day. Let's give it up properly. Thank you.
Thank you very much. I was wondering whether the introduction was the presentation. Yes. I bet you it may be longer than the presentation. Let me first of all acknowledge Professor Lydia Aziato in absentia, the Vice Chancellor of the University of Health and Allied Sciences. She's such a phenomenal woman, and her ability to rally stakeholders around herself is one that is rarely seen around this country. Unless you deliver, she will not leave you alone. So let's give her a round of applause. Professor Paul Amuna, one I've worked with very closely whilst I was acting Regional Director of Health Service within the Volta region. And Mrs. Cecilia Senu, our development partners who are here today, members of our distinguished faculty, University of Health and Allied Sciences. Let me say a very good morning to all of you. I greet all of you in your respective capacities. Firstly, let me extend the warm regards from Dr. Victor Asare Bampo, who is the Chief Executive Officer of the National Health Insurance Authority. He would have loved to be here this morning, but because of other competitive engagements, he will not be here. But we would adequately fill his shoes this morning whilst having this particular conversation. I would like to bring you the global Ghana has one of the most impressive health financing mechanisms across the world. And when it comes to lower middle income, I can tell you for sure that we are a great resource to many countries. From one country to the other, have Ghana in those countries or to come to Ghana. As we speak, next week alone, we have Chad and Ethiopia coming to the National Health Insurance Authority to come and learn from our sisters. For Ghana is currently the middle section, one of the best in the world. We certainly have made from where we began in 1957, where first we, as a government, could finance everything healthcare. Obviously, our population then was just about 6 million. And since the population started growing, we and public health. And by across the country, that we all, everybody, that was something that could not prevail because it did not offer any social protection to the people of this country. So we've had quite a journey. Now we have since had the establishment of the National Health Insurance Scheme. Today my focus would be on primary health care financing and Ghana's pathway towards universal health coverage. Yes, indeed, we've had a very rich history, but there's still much more that we have to do as a country. So the first thing is that in the year 2003, Act 650 established what we call the National Health Insurance Authority. The funding sources were clear. 2.5% of value-added tax to be paid by every Ghanaian. So if you consume goods or services in this country, you're supposed to pay 2.5%. For SNIT contributors, all of you are to pay 2.5% of the SNIT contributions. In addition to that, those who are within the informal sector, so those who have workplaces not appropriately captured, who do not pay SNIT for their employees. When we say informal sector, those are the people we refer to. They have to pay premiums to be able to be part of this. And we have had investments also accruing to the National Health Insurance Authority as income. Later on, I'll talk to you about some financial leakages, and in blocking that, that would also become a significant revenue stream for us. What was very significant about the National Health Insurance Authority that was established in 2003 is that it was in response to the cash and carry that I just talked about. People walked into facilities, and if they were unable to pay for healthcare, they would perish. It was that bad. So the National Health Insurance Scheme at a point was looking at how it would pay for disease conditions. So as a result, 95% of Ghana's common disease conditions were captured under the National Health Insurance Scheme. What was significantly missing was preventive and promotive healthcare. Yes, we pay for antenatal care. Along the line, we had free maternal health care. But certainly, there were so many other aspects of preventive and promotive health care that had not being captured. So that also reflected in the way we reimburse for healthcare within Ghana. So at this point, I'll say that when it comes to the country's health financing scheme, government, through the National Health Insurance Authority, funds about 56% of our healthcare. 26% is funded out of pocket. Then we have the development partners funding about 17%, but at present they fund about 4% because of the effect of the international health financing regimes. We all know that USAID has withdrawn. They used to take care of very critical interventions like HIV, AIDS. And as Ghana also matures, we are now a middle income, lower middle income country. Gavi will no longer give the financial interventions that it used to give. By 2030, we should be able to pay for all our vaccines. So this actually calls for critical retrospection and deeper thinking on how we should proceed as a country. What is key is that there ought to be a paradigm shift. Each dollar invested in preventive healthcare saves about $3 to $7 in curative care cost. We've also, as an authority, had engagements with the UK National Health Service, NHS, and we've had some cost-effective analysis, returns on investment for preventive healthcare investments. And this actually corroborates with the evidence that is being presented by the WHO as well. Mind you that at this point, non-communicable diseases such as hypertension, diabetes, and cancers also poses or gives us a very significant burden when it comes to healthcare financing. And these are things that actually can be prevented just by lifestyle changes. Our maternal and child health mortality is something that we have done well with over the period. But all of you would agree that at this point, there are still significant challenges, because you look at our data that was presented to us at the last National Health Forum. Clearly, our maternal mortality had slightly gone up. Yes, there are periods that it goes down, it comes down. But that just tells you that we are still stagnating, and we still need a lot of investment in that area as well. So because of this, there has been a lot of policy deliberations, especially with academia and practitioners within the health sector. There's a need that we expand the benefits package to include more preventive and promotive healthcare. Bearing in mind what these investments can actually do, there's also a need for us to shift from the fee-for-service arrangements that we have for our medicines, the Ghana diagnostic-related groupings. Those who are in the health sector or the healthcare providers would better appreciate this. To, when necessary, population-based payment methods where people will actually focus more on health outcomes than driving the volume of claims that they present to the National Health Insurance Scheme. There's also the need to plug fraud and claims leakages. Across the world, this is not peculiar to Ghana. Let me actually issue this disclaimer. Certainly, there would be claims leakages. And it's estimated that every insurance scheme would have about 10 to 15% of claims leakages. Ghana currently pays about 3 billion cedis out in claims liabilities. If we to increase this volume by 100% this year, which we're going to do, it will mean that in 1 year, we'll be paying close to 6 billion cedis when it comes to claims liabilities. And if the leakages is estimated at even 10%, so that should tell you that over 600 million yearly will be wasting away. So it is very important that we also take steps to block that. Anecdotal evidence even shows that Ghana's health insurance scheme has greater leakages than 10%, 15 to 20%, so about $1 billion, will be leaked out if we are not very careful. So if you block this, that becomes another revenue stream that will help us when it comes to health sustainability, health finance and sustainability. There's also a need to strengthen governance oversight. We are watchdogs in this endeavor. We want to be as transparent to the public as possible so that in return, everybody is held in check, that we all focus on our common objective. So whilst at that, let me present to you the current thinking around Ghana's health finance and reforms. I've painted a picture of what it looked like before. It was mainly the National Health Insurance Scheme that was taking care of about 56% on behalf of government. If you look at the white box, that is what we are fighting. The user fees, cash and carry, that still exists. That is what we are supposed to fight. So in 1990, that white box would have covered the entire box because there were no safety nets. There was no national health insurance scheme. We did well with the national health insurance scheme. Our population coverage gradually moved up. Currently, we are, as of end of year 2025, 66% of the population had been covered. Being covered is good, but the quality that it offers the populace is also something that we ought to discuss. Because at present, we also have illegal out-of-pocket payments, even with those who have the National Health Insurance Scheme cards. So it's something that we have to collectively also work on. And by the time I finish this presentation, I would appeal to you to play very significant roles in some of these interventions that we are looking at. So having said that, we noticed that preventive, promotive healthcare was something that was lacking. Not because of anybody's fault, but as we transitioned, clearly it became clear that the burden of NCDs and its complications on Ghana's health finance was very heavy. And the only way we could prevent that is by introducing preventive and promotive healthcare, which is one significant reform that the free primary healthcare is going to bring. The other significant reform is that every Ghanaian, so you see that when you look underneath this population coverage, 0 to 100%, so it is envisaged that every Ghanaian would have access, whether you have the National Health Insurance card or not. We are going to facilitate everybody, facilitate everyone getting onto the National Health Insurance scheme. We are certainly going to facilitate that. But in the event that somebody does not have, we still have to provide it for that person. And this would actually be applicable at the CHIPS compounds, the health centers, the clinics, maternity homes, and the public health units of polyclinics. So that would mean that if you go to the hospital and they pick you, you go to the CHIPS compound or the health center and they say, well, your BP is reading 200 over 100 milliliters of mercury, we would have to be referred to the next level. So in going to the next level, the district hospital, the regional hospital, the tertiary hospital, you would certainly need that national health insurance card. So what we do is that when you come, we give you a temporary identifier, but beyond that, we facilitate you getting the national health insurance card so that you do not have to face the cash and carry syndrome when you move beyond that. And currently, we have an incidence, a very high incidence of non-communicable diseases and complications thereof. And I can tell you that across the globe, Ghana has one of the highest incidence of non-communicable diseases. And in 2024, you'd remember that dialysis was something that was very topical. And people were going there or getting into end-stage kidney disease because we had missed them. We had not picked them up early enough. These conditions, you pick them up early, you are able to manage. Monthly doses of hypertensive medications won't cost as much as having to put somebody on dialysis for a very long time. So taking care of some of these non-communicable diseases became obvious to create that safety net for people within the population. So that is how come the Ghana Medical Trust Fund was established. And at present, they've started rolling out their services. So that is a separate entity on its own. So that's our second health financing institution funded by the state. Yes, our second institution funded by the state. So currently, they are covering 8 cancers. The first 3 cancers, prostate cancer, cervical cancer, and breast cancer for adults. And then you have the soft tissue sarcomas for children, acute lymphoblastic leukemia, Wilms tumor, retinoblastoma for children. So that's a very good step. Beyond that, they are going to add all other complications from NCDs, actually based on the impact on the population's health. So this is the current thinking. So what we are doing at the base complements what the National Health Insurance Scheme is doing at the district, regional, and tertiary facilities. And if anybody happens to find him or herself where the person has complications from non-communicable diseases, you have the Medical Trust Fund that would actually take care of it. So these are complementary in nature. So with this said, we'll read through the rest of the presentation. So to ensure sustainability, a lot of conversations have come up. The first is that you've talked about increasing the tariffs that you're going to pay. Certainly, to come with marginalization of health services. A lot of Ghanaians are not going to hospitals with national health insurance cards because they believe that when they go, they will have to pay. But when tariffs are increased, we expect that utilization will go up. So that there would be pressure on the scheme. How are you able to manage that? Aren't we going to break the back of the scheme? The other consideration that we have scaled is that at a point in time, we had competing needs on the health sector and the health sector. So what was done was to cap the National Health Insurance Fund. It means that if the NHI was entitled to maybe 100 cedis a year, we cap it at 60 cedis and we can use 40 cedis for other interventions. So with the advocacy that you actually helped with, that National Health Insurance Fund was uncapped upon the directive of the President. So currently, the NHI has an additional 30% of funding from what it used to get, so from 6 billion to about 9 or 10 billion last year. So this gives more fiscal space that has allowed some of the urgent policy interventions. Beyond what we're doing now, there's actually a lot of requests for additions to our benefits package. Day in, day out, we have requests. That would mean that any additional benefits package that you bring on board, you should be able to take care of it sustainably. You don't want to start and then you stop midway. So, and trying to soak up that pressure, one thing that Ghana is doing currently is to also look at other means of revenue mobilization. Yes, to start with, a certain proportion of the National Health Insurance Fund is supporting the Ghana Medical Trust Fund. But they have also putting enhanced mechanisms to mobilize resources from the private sector and from international organizations. And that is yielding some significant results for the country. In addition to that, there is also a drive to make sure that we get a percentage from our extractive industry to support them. So this is all money that would come to the health sector that was not there before. And this is supposed to help with sustainability. Now, when it comes to fraud and abuse, what I would say would be the third most relevant revenue stream. It sounds ironical, but if we are able to block the fraud and the leakages within the National Health Insurance Scheme alone, we would have the third highest revenue stream. It would only be beaten by our income from the National Health, from the 2.5% of VAT and what we pay from SNIT. Those will be the two other revenue streams that will beat it if we are able to block that leakage, estimated at over 600 million cedis. So we are putting in place stringent measures. So as we speak, now we have verification mechanisms that we are rolling out. So every patient goes to the facility, we have to generate a one-time access code for you, just to make sure that you are there in present and you are actually receiving health care, and the National Health Insurance Scheme is actually paying for what it's supposed to be paying for. And there are some inefficiencies that we have to also weed out. So at present, or last year, 2024, our medical loss ratio, that's the amount of money we used to pay for healthcare directly, claims, was 55%, and 45% was administrative. This year, 2025, or last year, 2025, we moved it to 65%. Our aim is that by 2030, 80% of the revenue we get would be used for direct healthcare cost, and 20% would be administrative. This, enhancing our efficiency, would also make sure that we have long-term financial sustainability. I've told you about how important it is to invest in preventive health care as well. So with that, I'm sure I've been able to adequately paint the picture of what the free primary health care presents. It's going to give us universal access, irrespective of your socio-economic status. You should be able to get health care at the basic level, the CHIPS compounds, the health centers, the polyclinics. And there's no discrimination, because whether you have the National Health Insurance card or not, you would be seen. But we take cognizance of the fact that beyond that, you will still need your National Health Insurance card for the primary hospitals, that is district hospitals, for your secondary facilities. So we would facilitate you still getting your National Health Insurance card, because our aim is that the out-of-pocket payments that I talked about in the beginning, which stands at 26%, higher than the international thresholds, is something that has to be reduced as a matter of urgency in Ghana. So this would speak to equity and social protection. The benefits of prevention and early detection, I need not belabor that point as well. And the complementary nature of the National Health Insurance Scheme is something I've adequately and eloquently spoken about. Now, we can have a look into the services that we are going to begin with. And before we got here, there was a lot of stakeholder engagement. So we took into consideration what is being handled already by some vertical programs. So if there are conditions that is being taken care of already, preventive conditions that's being taken care of already, we do not go there as a health insurance scheme. So the virgin areas where we had gaps, at present you cannot walk into a facility and say you want your blood pressure checked, or you can't have your blood glucose testing done for free. You would certainly have to pay for it. So we have to make sure that there are logistics in these facilities, and then in addition, we provide the funding for it. One of the things that the free primary health care is also looking at is the administrative cost of delivering preventive and promotive health care. It's been a space that has seen dwindling support over the past few years. We had something we call MCHIPS. Those who are in the health sector would identify with that. Beyond that, we had the COVID-19 support for essential health services. That has also come to an end. So before people are able to go and deliver these preventive services, it's really tough. Sometimes the health workers would have to use their own money. And this means that it is not sustainable. So the free primary health care also seeks or is going to plug that gap so that we have reliable and also sustainable funding for delivering all primary health care services, which obviously includes immunization as well. And this would be reviewed from time to time. So the current NHIS model, let me just reiterate, is currently individual service-based. But we are now looking at population-based healthcare delivery and population health outcomes. So this is a great incentive for all of us to get on board. So like my Minister of Health will say, we are moving from sick care to health care. And we are introduced for those who are in health economics, strategic health purchasing. We are going to use population-based payment methods for the preventive and promotive healthcare services. And because this was academia, mostly academics gathered here, I just put in this slide to tell you the difference between the curative component and the preventive and promotive. So with the curative, how is the payment being done? You see patients, you present your claims, we pay you. But for the preventive, we recognize the fact that teams would have to get ready and then go to the field to deliver these services. I've been at the district level before. I know how difficult it is if you don't have fuel in your motorbikes to go from community to community. So we pay them prospectively. So every quarter you receive your money, you are able to go and render these services. So because of time constraints, I may not go too deep into this, but I'm sure that we'll have more opportunity to engage during the question session. But this slide speaks about how we finalize the population-based payment rates. And we believe that as a country's strategic purchaser, everything that we do, we have to ensure that we carry all our stakeholders along. So if we say we are going to pay people for services they are going to render, it should not be we prescribing it for all the other stakeholders within the health sector. So we come together with academia, we look at the empirical evidence. So what is the population coverage? Which category of people would have to benefit from particular preventive interventions? How much is it going to cost? So everything is dependent on the empirical evidence that we collect. Then beyond that, we engage the stakeholders that in practice, actually, what are some of the unseen costs, indirect costs that they're in, so that we capture all these to make sure that it actually reflects the existing economic circumstances. Then we ensure sustainability of the scheme and viability of providers, because if the providers are unable to sustain the kind of health care activities they have, then whatever we are doing would not amount to anything. So these investments actually align with governments or the global trends. I've talked about the Abuja Declaration, where we are supposed to be doing at least 15% of our budget, or allocating 15% of our budget to health. Ghana currently is doing close to 7%. We've talked about, or the Lusaka agenda is also one thing that guides us very much, which calls African states to lead their own health financing trajectories. So you look at your needs, you look at how you're able to mobilize resources from within to support this. And obviously our own Accra Reset, which was led by the President of the Republic, which has gained a lot of traction across the African globe. We've had several engagements across the world, from Geneva to Addis and to Nairobi as well. At all these fora, you could see the excitement that a lot of the African countries bring aboard when it comes to we taking charge of our priorities and mobilizing resources from within. And for us at NHIA, we are the strategic purchasers for this country. We have to ensure that we have value for money, and everything that we do would have to enhance the efficiency so that we mop up more funding for the system. So if we are going to invest in preventive and promotive healthcare, we know that is going to affect the incidence of hypertension, diabetes. When that incidence is low, then we know that the incidence of complications will be lower. Then that would mean that government will not be spending too much on such conditions. So medium to long term, we are going to save a lot of money. But in the beginning, it appears to be something colossal that may drain the budget. But if we sustain this of time, next 5 to 10 years, we should be reaping from our benefits. That is what countries like Singapore have actually done. So Singapore currently, if you look at the current health expenditure per capita, is lower than most of the developed countries. And this is lower incidence. So that is Ghana's vision as well. So our partnership with you, academia, that's why we're extremely grateful to our distinguished professors and academics who are here, and we thank the Hope for Future Generations for bringing us all here together. We need to generate robust, context-specific evidence for health system decision-making. I talked about the need for empirical evidence when it comes to strategic health purchasing, and that can only be done by academia. And let me acknowledge some of you sitting here from the very beginning of conceptualizing the free primary healthcare. A lot of academics have played a key role. Our costing, for instance, was led by University of Ghana, Professor Novinho, one of the most accomplished health economics in Ghana. Together with his team, we had WHO very much a part of it. A lot of our organizations also contributed, funded, and also gave us the necessary academic support for us to get to this point. Then we need to enhance our efficiency, and one way that we can do that is to conduct independent health technology assessments. So during the introductions, I was happy when I heard that the Dean for Pharmacy is also the coordinator for the health technology assessment. So a member, good, for the HTA team. And this shows me that even before we leave here, we have found some viable partnerships that we have to nurture and develop in the interest of health finance and sustainability in this country. We need to publish on some of these key interventions, because that's the only way we can leave our digital footprints as a country, and also provide the necessary mentorship for so many other countries who wish to learn from us. So we also, as the National Health Insurance Authority, would need a lot of support when it comes to operational research. You know how it is when you are always in the field running policy engagements, implementation, you are chasing your key performance indicators. To sit down and even do one literature review is very problematic. So our friends in academia who are well versed in some of these things would need to come and support us with operational research and evaluation studies, because we actually need to know where the gaps are, even as we proceed with the implementation of new policies. And let me say that these policy implementations are actually ambitious. Now, in interfacing with the public, we all know the kind of reputation that academia holds, students hold. The committees trust your voices. And with some of these changes, it would require that we carry the population along. And we are just appealing to you, together with our esteemed organizations like HFFG, to help us with the community engagements to improve NHIS enrollments and to appropriately educate the public on why we need the paradigm shift from the predominant curative care to the preventive health care that we are all looking for. That is one good intervention if we actually want to have sustainable health financing in this country. So the health financing lexicons, the language is something that we have to imbibe in our health workers, professionals from the very beginning, because all of us contributing from various departments will help us to develop that critical mass that would put health financing as a priority in this country. Our percentage GDP spent on health is below the international standards. When you look at Abuja Declaration, Ghana is currently doing 7%. So that tells you that we should be able to push it to 10, 11, 12%. The ideal is supposed to be 15%. So many things that we can do together. And some of these would require very tough decisions. So if we want a percentage of revenue from extractive industry, it will not be a walk in the park because there are so many competing demands. But if we are able to project this as a national priority together with academia, we believe that we'll be able to mobilize more resources. So these public discourses and policy consultations should not be, today should not be the last of its kind. And I was very happy when I heard Professor Lydia Aziato saying that this engagement actually would have to be institutionalized, that at least we should have it once a year, and we should be able to tell ourselves year after year how far we have gone in providing health for especially the most vulnerable people within this country. On this note, let me thank you for your attention.
To give it up for him once again. All right. Thank you, Dr. Sedanu Jokoto, for such an important delivery. All right, so we are grateful. We'll continue. We'll take one more presentation, and we will go out for a short break. But before then, let's take Professor Martin Ayanori will be our next speaker. Before he comes in, I want to give you a brief of him. So Professor Martin Ayanori is an associate professor of health economics and policy and the foundational dean of the School of Graduate Studies at the University of Health and Allied Sciences. He published research spans through health systems, strengthening economic evaluation in health, health policy reforms in low and middle income countries, quality of life, inequality and inequities in health systems, among others. Professor Ayanori has authored over 200 scholarly peer-reviewed papers in high-impact journals. He has held previous positions as a visiting professor at Queen's University, Canada, a two-time fellow at the Johns Hopkins School of Public Health, and a visiting research scientist at the Royal College of Physicians of Ireland. Dublin, he's a recipient of the several travel awards as an academic to present his work in workshops and conferences around the world. Professor Ayanori is a member of the Royal Society of Tropical Medicine, RSTMH UK, a member of the WHO Health Financing Technical Network, a collaborator to the Ghana Global Burden of Diseases Network, University of Washington, USA. He is also an active member of the African Health Economics Policy Association. He is a member of the WHO Technical Working Group on measuring the distribution of the healthcare workforce. Professor Ayanori has consulted for several organizations and institutions, including the WHO, USAID, World Vision International, UNICEF, World Bank, and United Nations. With a round of applause, let's welcome Professor Martin Ayanori to give us his presentations. If we are clapping, I wish we do that better. Thank you.
Thank you very much for your kind introduction. I want to believe that those who are online can hear us clearly now. As I do. Very good morning to everyone here. Professor Paul Amuna, the chair for the symposium. Professor Lydia Aziato, Vice Chancellor, who has left us. Chief Director, Hope for Future Generations, who is here with us. Our distinguished guest speaker, Dr. Ajiku, who splendidly just delivered his lecture. We have deans and us who are here. Please, you are duly acknowledged. My other speakers who come after me for this morning's session, colleagues from other sister universities too who are here, private and public sector actors who are here, the media, all observed. It is not a cliche to say that primary healthcare is the foundation of modern healthcare systems. So before I go on to my slides presentation, I want to make some brief comments. But it's more imperative to say that there's a need for us to present with a and resilient healthcare system. Primary healthcare financing in low and middle income countries faces persistent challenges due to all the problems that all of us here in this we are aware of. Now, in the case of Ghana, Ghana's primary healthcare financing landscape illustrates both progress and persistence, as our guest speaker has. And many of them, the National Health Insurance Scheme is dealing with them in a more drastic way to address them. But that not said, there are still few things that we gathered in this room we want to look at. We want to discuss passionately how we can collectively address that. Despite our advances, we still have challenges when it comes to immunization financing. I'm sure Professor Justice Novivon, when he takes the stage, will walk us through what the challenges are and how we can be able to advance that. And I'm happy to say that Hope for Future Generations, one of the partners here, have been doing extremely well because it's one of the areas that they have been advocating when it comes to immunization financing. Right. So I want to start off by saying that I want to declare interest in based on my work as an academic, and therefore it's for the purpose of reformation and for us to see how we can advance as a country. So this is the outline of my presentation. It's going to be brief, and I'm sure that during the panel sessions, if there are comments or discussions that come out, we can look at them. First of all, I want us to look at why we are focusing on health financing as critical when it comes to primary health care. I'm taking us back to memory lane. We all know that the WHO World Health Assembly in 2005, World Health Assembly 58.33, that was when the aspect or the issue of sustainable health financing was first brought up. And it challenged the world. So 21 years ago, this resolution was brought up by WHO. How can we think ahead to fund health? So right after that WHO convening in 2005, the West African Health Organization took the steps the following year to be able to accelerate progress towards coming out with more sustainable ways by which we can fund our health. But it took us a number of years in Ghana here to come out with our first strategy, which is in 2015. So just look at 2005, when this was brought up at the World Health Assembly. Then a year later, the World Health Organization in West Africa came out with clear guidelines on how we can proceed. But not until 2015 that we as a country then put together a strategy, a national strategy on health financing, even though there were discussions that were going around, but they were in silos. But this was the first document that consolidated all the ideas and how Ghana's future for health financing could be at the long run. I'm bringing this for us to reflect on what our guest speaker just said. Yes, we are highlighting and focusing on primary health care, and with a strong political will and commitment to make it possible after a long while. After a long while, because the journey to primary health care did not start today, and we are very familiar with the trajectory from the Alma Ata Declaration in 1978 up till now. Efforts have been made to be able to see how we can make it more practical and more sustainable. In fact, if you look at our national architecture or system of primary health care, I describe our primary health care today in Ghana as functional but not efficient. And we all can attest it's functional to a certain degree, because functionality, if you look at all the structures of our primary health care system, they are not even in place. If you want to say we want to start from the chips, it's not everywhere that we have chips. If we want to say we want to start from the clinic level or even district hospitals, we still do not have across. But I'm sure that one of the strategic policies that the present government will be doing is to fix this functionality. But the efficiency too has to be there as we transition along. Now, the call for all countries to think about sustainability when it comes to health financing, these are excerpts from the WHO Health Assembly 58.33. They are clear in terms of what we must do to be able to develop sustainable systems that can fund our health. And there are things that have literature. So when we look at Ghana's strategy has outlined key objectives. We must be able to achieve certain key objectives if we want to advance financing in a more sustainable way. And I want us to just reflect on them. The first talks about the need for us to go beyond just the traditional way of mobilizing funds. What are the other extra innovative ways? And that's the reason why we are all in this room today, to discuss and to see what are the practical ways by which we can improve resource mobilization. A key objective in that our financing strategy as a country is also to ensure that once we raise the revenue, we should be able to allocate it efficiently, allocative efficiency, and ensure that the right funding goes to the right spending places. So like our guest speaker said, strategic purchasing, where should we put our monies when it comes to the various domains within the health sector. And the third is to be able to strengthen governance and transparency, and our guest speaker spoke about the need to plug loopholes to be able to address certain bottlenecks when it comes to the revenues. Promote equity, which is critical, because financing is supposed to remove barriers. So if we are developing a financing mechanism and we are not addressing the underlying barriers to access to care, then we are not addressing equity in a way that promotes healthy living. And of course, the last one talks about partnership, motivating and stimulating service delivery and quality through partnerships. How can we bring other sector players, our ones that we already know, to be able to improve what we want to do? This is a bit cloudy, but I outline all these for us to know that in Ghana's health financing strategy, there are 15 clear things that we must do as a country if we want to achieve sustainability in our health financing scheme. And for the topic that I'm going to speak briefly on, is on innovative health financing for primary health care, which dovetails or falls directly within the strategic objective 4 of our national priority. But however, if you look at all the strategic objectives outlined in our policy, all of them are very essential. It talks about improving revenue resources, being able to allocate it efficiently, in areas that matter, cutting waste, and also ensuring that we implement a very strong M&E systems across all our health sectors to improve what we do. With this, let me just say. So when we talk about what do we mean when we say innovations in health financing? So innovations in health financing goes beyond what we already know, which is just to raise money to fund health. So it goes beyond that in terms of looking at blended and hybrid financing schemes that gives opportunity for us to combine both public, private, and philanthropic support. People are willing and able to provide some amount of funding. In fact, some substantial amount of funding to fund health as corporate institutions or even it would also include results-based financing for us to think beyond that. Can we, as a country or Ghana, begin to pilot models such as results-based financing that has been done in other contexts, such as Rwanda and in other countries? What are the lessons? And I'm happy that because we are all academics who are some of these sessions to the research gaps that we already exist. Quite recently, we had a national research fund being launched by the president. I'm hoping that as academics or people who are in the research phase, there are many things that we still have to go into to find the evidence that can strengthen us. An example is how based finance. Simply is to looking at how can we provide that support to institutions, particularly pharmaceutical institutions, to mitigate risk when it comes to making sure that the supplies that we need, essential drugs and commodities, are available all the time to fund health. So financing health, yes, raising the revenue, but beyond raising the revenue, what guarantees can we provide for corporate institutions? Investment corporations will always exist and be able to offer the needed support for our health systems to function. So in defining innovations in health financing, we look at it in 3 levels: raising the revenue or getting the funds, ensuring that there's efficiency in that funds that we have already, and this goes directly to paying for results. That could be results-based financing, or ensuring that we provide the needed mechanisms to reduce waste within the system, and then also ensuring that services that we deliver are better and address population health gaps. When we do these things, then we tend to achieve the core objectives of the primary healthcare system, which is to improve population health. Now, I have already explained that innovations in healthcare financing must go beyond the traditional way of just generating funds to do these 2 other things. The first one is partnership building. Partnership building. And the partnership building here is for us to be able to build capacity in both technical and financial. The technical and the financial goes in terms of, okay, we have raised the funding, which is the traditional way. What systems can we build right from the primary healthcare level? It's because we are looking at the primary healthcare level here, primary healthcare level along those structures. What systems can we put in place to ensure that there's technical capacity and there's financial capacity to sustain that partnership? And partnerships here also goes just beyond partners within the health space to others that may be directly involved in health financing or health service provision, or provide other pseudo functions that may not be directly related to health. And then the other aspect of innovative health financing has to do with accountable systems, accountability. How do we account for the principles of equity, principles of ensuring inclusivity in access to healthcare along the primary healthcare boundaries that we are defining. So these are very essential. If we are designing innovative financing systems, then we must reflect on these core principles, because without these core principles, then the financing schemes that we are going to design or be proposing as a country, there would be some gaps in it. And the first is side effects. And to answer the question of side effects, our simple question we are posing is, to what extent does financing mechanisms create positive or negative side effects? Does it bring positive or negative? Does it improve health outcomes? So if we are targeting a specific financing mechanism or scheme, like to impose taxes on alcohol, we know the side effects of alcohol. Are we raising that revenue or money to target conditions that come from persons who probably would be indulged in alcoholism, or we are broadening it to other areas that may need that help or support? Any financing scheme must also show progressivity. So, for example, quite recently we have the incidence of mobile tax that was flagged by Ghanaians. That's a regressive tax. So if we are designing any financing scheme, it should be progressive in terms of the capacity or ability of people to pay. And the progressivity here is in two levels. We'll look out for vertical equity and we'll look out for horizontal. So if it is vertical, we are looking at those who have the ability or capacity to pay. It means that we must be able to tax them more to generate that funding from them to support in other areas of funding health. And then when we talk about the horizontal, we are looking across broadly. If you have the same level of income or your socioeconomic status is the same, can we look at models that will look at persons whose socioeconomic status are higher, they pay more. Those who are middle income, lower income, they pay at different thresholds depending on income levels and socioeconomic status. So whatever financing scheme that we are designing should be progressive in such a way that it does not bring untold hardship to those who would have to pay for that. It must also address the issue of stability. And stability here, we are looking at a system that is predictive in such a way that we don't introduce a system of financing that is not long-lived or the longevity is very short. Our guest speaker spoke about efficiency and bottlenecks in terms of revenue losses, and that falls flat within the aspect of administrative efficiency. And I'm happy that the National Health Insurance Scheme, based on his words, that they are working towards ensuring that around 80% of monies go directly to fund health, whilst administratively they spend 20%. And I think that once we do that, we are improving on what? Administrative efficiency. Because it's not good to mobilize more and spend more administratively rather than more of the funding going directly to fund what is essential. And of course, the last one that I have here is sustainability, which is critical. Every financing scheme must be sustainable. If we are not able to ask the question whether, is this scheme sustainable? Does it promote longevity beyond the scope of this administration? If it does not, then we need to ask the hard questions. So this brings me to the critical innovations that have been done by this present administration. We have the Ghana Medical Trust Fund, and we have the free primary healthcare, which are very laudable initiatives. But the question that we academics have to move into now is to generate that evidence that tells that what can we do to be able to sustain this and to let it stay and improve in our health systems. Now, there are several financing strategies for primary healthcare globally, but I want to zero into NCDs, just the case of NCDs, and talk about what is being done elsewhere when it comes to NCD care. And largely we know that government or the public sector is the largest funder of health. So public financing is critical, it's the largest. Beyond public financing, which comes directly through taxation or earmarked funds that governments allocate during their annual budgets, Other jurisdictions also have sin taxes, which we all know, which they introduce, the slab taxes on tobacco, alcohol, sugary drinks, and all the other things. And I know that there are colleagues in UHAS here and with the University of Ghana who have been working over the years on how sin taxes could be a major revenue source for Ghana when to fund health. So that's one other component. The third one is pool procurement. And in the case of NCD Care, if you look at what happens in NCD Connect is a global platform that ensures access to medicines at a very low cost. So averagely 50-70% of the cost is afforded because of the systems and structures they have put in place. So the question is, can we have a system where we have pool procurement for access to medicines for free primary healthcare systems in Ghana? In that case, it means that our commodities that we'll be buying, we may be buying it at a much reduced cost that can enhance access to medicines for our primary healthcare systems, ensure that we reduce bureaucracies and timely treatment outcomes for patients. A clear example that is also used in NCD care in some contexts is task shifting. Now we are talking about free primary healthcare. So free primary healthcare means that we have to be efficient, effective in how we even raise revenue, we spend revenue, and we account for the revenue. Beyond that, it also means that we need to think about how can we reduce the cost of healthcare delivery at the primary healthcare level. So oftentimes when we talk about health financing, we're thinking about, okay, let's raise more revenue so that we can spend to be able to take care of health needs. But let's flip the coin to the other side. We are talking about health financing. Can we also think about strategies that can reduce our healthcare costs at the primary healthcare level and not necessarily to increase it? So this is where tax shifting comes. So I'm hoping that our National Health Insurance Scheme and all the other partners who are working on the free healthcare system can look at how we can introduce more tax shifting rules within the primary healthcare level as a model to finance healthcare at a lower cost. It should be cost effective. We should not just be looking at raising money and spending because we want to ensure that it's free primary healthcare. Although that is essential, but the other elements of cost reduction should guide some of the decisions that we make at the national level. We also have quite a number of examples that I'm sure that many colleagues know. This published by WHO, Ensuring Healthy Lives for All. They've outlined a number of efficiency and equity principles, as well as ways by which countries can raise money domestically to fund healthcare, primarily at the primary healthcare level, where close to 70% to 80% of the population needs are much abound. So these are critical things that I think that maybe perhaps during our panel discussions, if they come up, I'm willing for us to discuss them more into details and to look at what can be done. Our guest speaker has already spoken about the health technology assessment, which is here, that Professor Boabeng and his colleagues are actively engaging. Also here, when it comes to efficiency, is for us to look at provider payment mechanisms that must work in our context. I'm happy to see that the guest speaker displayed the various clear benefit package outlined for the free primary healthcare. It is important for us to be guided by the various payment mechanism models. We cannot use the same payment mechanism models within the primary healthcare or secondary or tertiary level. We need to be able to distinguish these clearly and ensure that they work for the greater good, particularly of the vulnerable. Now, before I conclude on the last aspect of what I want to say, I have made some few suggestions here in the case of Ghana. How do we bring about innovative health financing for our primary healthcare in Ghana? Since our guest speaker has spoken specifically on the NHIS reforms that are taking place, I want to highlight certain things maybe perhaps that they are doing or they are yet to do that can strengthen some of the essential things that the NHIS focus is on. And the first one for us as a country to be able to move towards innovations in health financing is to strengthen NHIS, which they are doing. What we must do is to target for 100% population coverage at minimum. And I'm sure that that's what he said they are doing. At no fee at all. And he mentioned that. At no fee, it means that everybody must be part of the NHIS. We must ensure that that mandatory within our clause of the NHIS law is enforced. But there are three approaches I want to propose today. And I want to say that there are three levels, three tier. Let me just go to the three tier levels. So we have a first tier, a second tier, and a third tier. And these all suggestions are to strengthen the NHIS. The first tier that we're proposing is to target an essential package of healthcare services based on clearly defined primary healthcare, which they have done. And as he admitted, they will continuously review this list as and when it changes. Package should reflect priority healthcare needs. I'm sure the prioritization has been done with broader stakeholders, as he has already said. And it should be delivered at a primary healthcare level. We have agreed on that as a country as we move ahead and as we declare free primary healthcare. And it should be at no cost. That's the first tier. And this first tier, everybody in Ghana must be part of the National Health Insurance Scheme. Everybody must be part of it at no cost. It's mandatory, at no cost. So everybody should be registered at no cost. And everybody who wants to access healthcare at the primary healthcare level, at the CHIPS compound, at the health center, and to some extent at the district hospital, should receive that help for free. Then we'll have a second tier, and the second tier should target insurance premiums-based benefit package. So that should clearly be defined by the NHIS. And once they define this clearly, it will enable private insurance market players to take up the space and know clearly what are the options that are available for them when it comes to the second tier that I'm proposing here. It should be administered under mandatory insurance scheme. So depending on your condition that you have, if you belong to this second tier, then you are registered or you are insured under this insurer once you have any condition that is provided for either within the primary or the secondary level of our healthcare system, you can have access to. Then it should also cover services that are not within the tier one. Yes, so services should be clearly delineated. So if our push is to ensure that primary healthcare is free, we must re-engineer our health system not to deliver primary healthcare services at the secondary level. Otherwise, it will not be effective. So if we are saying that primary healthcare is free, then primary healthcare services should not be delivered at the secondary and tertiary levels moving forward. Otherwise, it will defeat the purpose, and we cannot achieve that. It must be clear. If there's that high commitment, then primary healthcare services at the secondary and tertiary must cease. That will give the opportunity for care seekers to really go back to the primary healthcare level to seek for healthcare. Otherwise, there will be a challenge enforcing that. Then for tier 2, I want to emphasize that it should be financed through a combination of social, mutual health insurance. So the tier 2 will allow people to take up private health insurance, mutual health insurance, or any other social health insurance, in addition to the tier 1 package that they have, which is free primary health care. In addition to the tier 1 package that they have, which is free primary health care. In tier 2, we are proposing that tax funds should be made available to pay for the health care costs of the poor. And this is where the NHIS and the Ghana Medical Trust Fund comes in. So even though we are saying that in tier 2, you must have an insurer, we should be able to have a system where we identify the core poor and put them onto tier 2 mandatorily. We don't leave them out. That's inclusivity. That's inclusivity. You don't leave them out. So we are able to identify our core poor and register them for tier 2 mandatory. And that is funded directly from taxation, funded from the NHIS, or funded from the Ghana Medical Trust Fund, without any financial hardship to that category of people who fall within tier 2. And then the tier 3, you said, must be delivered under supplementary health insurance. So these are persons who need higher level care, who go into chronic conditions that require long-term care. And these require specialized services. These persons must be able to take up insurance. They must be able to take up a certain minimum level of insurance, and there should be a co-payment mechanism or system where public taxation caters for them so that they are not left out. So if you need any kidney transplant, there's a co-payment mechanism. It could be tax deductible where they get back the money. Then government pays a certain portion of it. That's inclusivity. Because if we want to ensure that we address equity in access to healthcare, there's no disease burden or type that should define exclusivity. It should be inclusivity, not exclusivity. So we will have to meet them at a certain threshold so that public funding can also be able to support them. Apart from the NHIS, another way by which we can be able to bring innovations in healthcare is to diversify domestic revenue. Dr. Jukoto has spoken quite a number of things about it. We talked about results-based financing, which is clear to all of us. Blended financing, as I said, we should be able to push more towards philanthropic support, public and private support coming together. We should exploit digital levies and micro contributions, even though this is not so good in our context here, but it's something that as people in the academic space, let's begin to look at it and put it forth out there. How can we be able to tax the telecos a certain proportion of their incomes to fund health directly in a certain way that helps us? And then we can also have guarantees for medical supplies and essentials through advanced market commitments. This may not be very clear, but this was just a picture to show that in various countries in Africa, there are various ways by which they are funding health. So we have tobacco tax, alcohol, airline levy, sugar levy, oil or gas, HIV/AIDS. There are various ways by which we can think about broadly in coming out with suggestions. Another thing I want to highlight is the need for us to promote private sector-led. Private sector is very critical. Private sector, where financing in health is going, we need more private sector participation, not just as active partners in the discussions like we are doing, but in funding it and ensuring that they are part of the processes for accountability. That is very critical to ensure long-term financing. Then we need to be able to advance evidence and knowledge, and that's why we in academia, our role is critical. There are many things as we are transitioning in our health financing landscape that we don't have knowledge on. Ghana Medical Trust Fund needs a lot of research to look at what would work in our context, what will not work. The free primary healthcare, that's a lot of knowledge gap space that we need to plug in. And as academicians, once we leave here, let's begin to discuss that collaborations that can help us to generate further evidence to support that. Then we must be able to build a primary healthcare informed by accountability and sustainable payment models. And these are just few examples that our payment mechanisms would have to be looked at. GIZ and its partners have done a couple of works that I've reviewed, which is very fantastic, and they can support us in that area. Now, there are a few things I'm ending here with, and permit me just to go back to this, to say that for us to advance as a country and come out with all the innovations that will lead us to a sustainable health financing now and in the future, we need to strengthen NHIS coverage and efficiency And here is to expand NHI's coverage to informal sector workers and vulnerable populations through targeted subsidies and enrollment drives. We need to improve reimbursement timelines, and I'm happy that we have more money coming to the NHIS now, which means that it's going to reduce the lag time and the payment periods that these health facilities have to wait for. We need to also diversify domestic financing. We've spoken about it, various models by which we can. And as academics on the table here, maybe after today, our discussion should center at what types of diversifications will work in our context. And we can take this back and conduct more research that will inform policy. We must ensure transparency in petroleum revenue allocations and public sector funding for health spending. And how can we do this? Strengthen how much we allocate for health and ensuring that funds are ring-fenced, which we are doing. But most importantly, we must guide the rhetoric where we say we are making commitments to fund health, but when you go into the actual budget tracking for health, it's different. So yes, the NHIS has been uncapped. We have about 9-point-something billion in 2025. How much of that went into fund health? That's the question. That's the question. How much of that went to fund health? That should be the guiding question for policy stakeholders and those who gather around the table. Then we must also leverage technology to ensure efficiency in some of the things that we are identifying to fund health. And of course, I will end by saying that we must enhance academia's role. Academia's role. And I'm happy that NHIS is saying that we would continue this dialogue to be able to generate the evidence that academia can bring on board to support us drive this discourse. So I would want to thank you here and end here, and hopefully if there are any other questions during the panel discussions, we can take them from here. Thank you very much.
All right, let's give it up for Prof again. Thank you. This was another lecture for some of us. He was taking us to primary health care, and at every end of sentence here, UHC, UHS, like, what is UHC, Universal Health Coverage? That's Professor Ayanorife. Let's give it up to him one more time. All right, so we are, I think, halfway through our program. Prof Chair, with your permission, we would want to seek about 20 minutes to have a short coffee break. So 20 minutes, all of us, Prof Chair has given his go ahead. So we'll spend 20 minutes in taking our coffee. And we'll right, by 11:35, we'll be back in this room to take our first roundtable discussion, which will be moderated by Dr. Mavis Paul Kwabla. So you are good to go. Thank you. So our snack is at the entrance as well. We'll be having our group picture outside whilst we take our snack. So the arrangements have been made outside for us to take the group picture as well. All right. Thank you.
Recording stopped.
Hello? Okay. Okay. Okay.
All right. Thank you. Hello. Please, let's get settled and kickstart our next session quickly.
The program. Let me share with you. Yes.
All right. Hello. Those who don't have access to the program outline, entrance, you can follow the program as well. Thank you. There is a QR code. You scan on the wall and have access to it. So let's get settled whilst we commence the next session. Thank you.
Okay, so before we begin the panel discussion, we'll have about 3 minutes for Mr. Stephen Atasigi to address us. Stephen Atasigi is the reason why we are all here. We've had colleagues coming all the way from Tamale. They flew to Accra and were picked up from Accra to Ho. And all that was made possible with funding from the Global Health Advocacy Incubator. His car broke down, so he managed to get here around this time. So Mr. Stephen Atasigi is the country coordinator for Global Health Incubator. He's a field epidemiologist, a certified project management professional. He has about 14 years working with the Ghana Health Service as a biomedical scientist, building capacity in field epidemiology and strengthening health systems across West Africa. He was involved in the Ebola response in West Africa. And just a few weeks ago, we had a wonderful webinar where he shared his experiences working in Sierra Leone and Liberia in the West African Ebola response. Yes. He's worked with the Africa Field Epidemiology Network in Liberia and Sierra Leone as a mentor and a technical advisor, respectively. And he serves as a WHO technical consultant in Tanzania, Equatorial Guinea, and Eswatini. So with a round of applause, let's welcome him to thank all of us for coming. Stephen, you can come here now. Okay, you can speak from there. That's okay. Thank you.
He mentored me as a resident field epidemiologist at the University of Ghana, and I'm always proud to say that. He taught me well. Okay, so honorable or distinguished chairperson, distinguished guest speaker, our highly esteemed academics, the media present, and all other honored participants. On behalf of the Global Health Advocacy Incubator, I want to say a very big thank you to the University for Health and Allied Sciences for once again accepting to host us. If I say us, I mean the Global Health Advocacy Incubator and our CSO partner, Hope for Future Generations. About 3 years ago, we had another very pivotal symposium on public health emergency financing. At the time, of course, when it was obvious that we've been hit as a country by the impact of COVID and having learned the lessons of how Ebola greatly also impacted countries within West Africa and even in East Africa, it was clear that as a country we needed to advocate for sustainable financing for public health emergency response, preparedness and response. And so once we thought of how to also go about it, we reflected on the impact of academic research and the voice of academia in shaping policy. And so we fell on the university and they did not hesitate to host us. It was a very, very awesome program, and we were very happy it happened. So based on that, we pledged to ourselves that we're going to maintain a relationship with the university and with academia. Bear in mind that academia has a very great impact on what we do. At the Global Health Advocacy Incubator and our CSO partner, we advocate for policy change, ultimately to save lives. And in doing that, we employ all the strategies available to ensure that we are making the case and amplifying our voices to the policy decision makers who need to make these policy changes. And to make a policy change, you need to first of all identify who your right coalition partners should be. And academia, for us, is one of the best coalition partners you can build when it comes to advocacy. We also acknowledge that a lot of research is done over the years when it comes to all sectors of our health system, be it finance or technical areas of health system strengthening. But you also agree with me that a lot of our academic work may remain on the shelves if we do not find a platform to project them and make them, transform or translate into policy. And that's why the team, as you have seen, advancing sustainable financing for primary health care, academic research, from academic research to policy making was taken. And we believe that this platform, after everything, we together as the group here would come up with some concrete message or advocacy, call to action for the policymakers to take action. And I acknowledge your presence without your presence. So, as you have come, I want to go back to that and say I acknowledge your presence highly. We don't take that lightly at all. You're a very busy person, we know. I was trying to book an appointment with his office, and it took us, So we know how busy you are. So we never take it lightly that you've made time to be here. We are so grateful. And also, it points to the fact that you also take this, topic of discussion very seriously. And we believe that, this is a learning session as well, as much as we want to also inform policy. And so, I want to quickly end by saying that together, let's all turn into advocates for health. It's good to see that the government of the day has prioritized primary health care by pushing for a free primary health care policy. It's also good to see that there's a lot of movement towards universal health coverage in Ghana. The indications are very clear that Ghana as a country is doing very well when it comes to universal health coverage compared to other neighboring countries, around us. However, it's obvious that we can't achieve universal health coverage or free primary health care if our sustainable financing for these interventions are not secured. How do we secure them? It's only when we put into practice the research evidence that we generate. As we know, money is what runs everything. Money rules the world. If you don't have the money, you can dream all you want, it wouldn't happen. And that's why we need to, as a country, begin to think about how do we domestically raise the revenues to fund our health. We have seen what's happening globally with the declining funding to health. So it calls for action and moving beyond just the policy rhetorics. So on this note, I want to call all of us and ask that we all turn advocates for health financing. We turn advocates for stronger health systems. As academia, let's also move beyond just the research and ensure that our research is translated into policy that drives our national growth, especially for health. Thank you so much.
Thank you. One more time. Yeah, thank you. So we will commence swiftly with our first roundtable discussion, which will be moderated by Dr. Mavis Paul-Kwabla. Let's give it up to her. She comes in and introduces her panelists as well. Thank you.
All right, good afternoon, everyone. A lot has been said so far, so we have the next 20 minutes to have a discussion on the topic, innovative financial mechanisms for primary health care service delivery, looking at health commodity security and the implementation measures. And so to do this discussion, I would first of all like to invite Professor Alex Menu, who is the Director for IHR in UHAS. Shall we also make welcome Professor Martin Ayanori? He has really given us a very detailed information on this topic. Shall we also make welcome Professor Samuel Esienbedu, who is with the National Vaccine Institute. And then finally, let's make welcome Dr. Dalaba Maxwell, also with IHR. So we are looking at innovative financing mechanisms for primary health care. We all know that primary health care remains the foundation of Ghana's health system. And it is so central when it comes to achieving the universal health coverage. But there is persistent financial constraints, which is affecting the availability, the accessibility, sustainability of essential healthcare commodities, including the medicine, the vaccines, the diagnostics, and other essential supplies, which are very important for the primary healthcare. While significant investments have been made in primary healthcare delivery, concerns remains regarding funding adequacy, procurement efficiency, supply chain performance, and accountability mechanisms. As Ghana seeks to strengthen domestic financing for health, there is a need to identify innovative financing approaches that can improve commodity security while ensuring effective implementation at all levels. So with my panelists, I have a few questions which I would pass on to them. So first of all, would like to start with, I'll start with the one sitting close to me, Professor. Yes, so Ghana continues to face financial constraints in sustaining essential health commodities. What innovative domestic financing mechanism offer the greatest potential for ensuring long-term commodity security without compromising equity and access? And what you can say briefly, we can pass on to Prof. Ayanori, who has just delivered the lecture, to also add something. Thank you.
All right, thank you very much. So, talking about innovative financing and sustainability, what we need to look at locally is the issue of the sin taxes. Martin mentioned that that model has been used in a number of countries and it's worked very well.
When we're happy, we drink alcohol. When we're sad, we drink alcohol. And if you look at the consumption rate of alcohol alone in Ghana, and if we are going to be deliberate about taxing alcohol, you would agree with me that if that fund goes directly into the National Health Insurance Scheme, it would help to solve much of the problem. The Philippines did it. They did it with alcohol, they did it with sugar, and it worked well. So this is something we need to avert our minds to. One other thing that we probably have not thought about is the natural resources that we have. What percentage of the funds from the natural resources comes directly into healthcare? It is not so clear. The money that comes from the natural resources actually goes to the pool. But can we be deliberate and say that 1% of all those resources should go directly into healthcare, and in that case, directly into primary healthcare? That will solve most of our financing issues when it comes to innovative financing. We have the natural resources, so we don't need to reinvent the royalties that we get from the natural resources. As a matter of policy, we need to engage and see if we're going to be deliberate. So that budget line would come directly into healthcare, not the bigger pool. Then we would be solving the problem. Thank you.
Thank you. Yes, Prof, you can also add.
Okay, just to add a little to what he said. So I want to take it from, we all know that innovative health financing revolves around 3 pillars. We are collecting the revenue, we're doing pooling, and then we are purchasing in terms of what we want to. So I want to say that when we are talking about innovative health financing, as Prof. Asian said, yes, we're looking at how to bring in more money. But beyond how to bring in more money, how do we ensure efficiency in the use of that money? And that's where I want to come from. So we must re-engineer how we spend every CD to meet our healthcare needs in terms of the purchasing models. So we need to look at, quite often yes, it's good to experiment other purchasing models outside our context, but we need to be able to generate context-specific models that work best for us. How we spend every CD along the health budget lines. Because in itself, that's an innovation. Innovation, being innovative here is to see what works best within our context and what can solve our problems practically, not what works in other contexts, whether it solves our problems practically. So beyond bringing in the money, yes, how do we spend this money? How do we ensure efficiency? How do we ensure accountability? How do we ensure that the areas we spend the money we raise addresses the critical primary healthcare gaps that will continue to strengthen our primary healthcare systems and make them more efficient and effective? So that's one side. Then the other side also has to do with, in raising more revenue, how do we continue to protect the vulnerable and the poor? How do we ensure or guarantee social risk protection? That is very critical. We are defining now a benefit package for free primary health care. We're going to say that everything within the free primary health will be paid for, made freely available. Are there elements or components by which we can innovatively say that if you need this extra package of healthcare within the primary healthcare, it comes at this cost? These are questions that we must ask. So being innovative doesn't mean that it should be necessary, as long as it is available for that addresses a public health need and requires that service. It could come at a cost, but a minimum. It should not be regressive in such a way that it will further poor into poverty. So these are things, questions we have to always ask and see how we address them as we are thinking about patients in healthcare financing. Thank you.
Okay.
Thank you. Very much. My name is Maxwell Dalaba. I would also like to put on the aspect of collection. So we normally say national health insurance is mandatory. How many people know that it's mandatory? Have you ever enforced? Do you know that if you don't have national insurance, you can be taken to court? The German system, you cannot move without health insurance. What efforts are you putting in place? University level, when you are going to university, ask my German colleagues, without health insurance, you cannot read. Are we implementing this? This is one thing that we need to do. You want to get people involved, but are not making the people know it is mandatory. This is what we need to start thinking about. Most cases, my check shows that they just register, they don't ask about health insurance. This cannot happen in Germany. Now, the next thing is more about how do we go innovative? We have made a lot of noise regarding the card. What noise have we made regarding the national health insurance? If, for instance, you say, look, before you renew or you get licenses, you need to present your national insurance card. Roadway, you need to have national insurance card. Sometimes even common elements, they'll just get a task force. If you don't wear your helmet, you'll be taken to court. Have you done that before? One day you can just get up and say, if you don't have national health insurance card, it's mandatory, you'll be taxed. You see how people will rush to go and register. So let's look for innovative places that we know people visit a lot and say without national health insurance, you cannot register. And as I was saying, the DVLA is a very good way of getting it. And even tax force, you go to the market centers, we all know the formal sector is large in Ghana here. Have we made efforts? You go to market and ask, do you have? There can be tax force to force people to register. When you do that, you get 100%, but you get people who will go. Because I know people who don't want to go there because of time wasting. But if you go close to them, they are more likely to register. So we need to now make it mandatory, the voice go well, and there should be a tax force to force, compel people to register. Thank you.
Would you like to add, or I can ask the next? Will you like?
Ask the next question. But
Okay.
yeah.
All right. So beyond mobilizing resources, what are some of the major implementation barriers that prevent financing commitments when it comes to that come from the government to make medicines available, the vaccines? What are some of the barriers?
Thank you very much, Alexander Maino. I think immediately to talk about barriers, I'm going to think about the basic thing that calls for is money. If you ask anybody in the health sector or in any sector and you're asking about how we can finance or how we can sustain commodity and supply chains, whether in health or anything, next thing they ask you is about money. But I think my clearly articulated innovative ways in which we money into the system. But I see it. It is not, if we want sustainability, fetching water into a basket, you will not have in the basket. One part of sustaining the basket is sealing the whole basket. And I feel that ways in which we can innovate to make sure that the monies that we are raising from the limited sources that we have are channeled appropriately into and not into individuals' pockets. For example, we can have innovations, and I was talking during the break about technological infusions that we can make. For example, if we can have data on the claims in many of the presentations, but beyond that, we can risk profiling of various people who are providing services, right? If you're a service provider, you are looking at the claims that you are making, whether you are an outlier in the areas where you are, or you are overcharging, or something about you, immediately the system gives you a risk score. And so immediately you submit your claim, people with lower risk scores get quicker reimbursement. And once we are able to get that, it will take time to get out of a poor risk score. And I think sometimes talking about credit scores for Ghana, I think we need to let people know that there are consequences for you cheating the system. And if we are able to hold some of or the resources that come into the system, then we'll have issues and things addressed. Because we must be careful that anytime you introduce intervention into a population, implementation tells us that the risk of inverse equity hypothesis. In the inverse hypothesis says that if you send a new intervention into a community, the richest population will get it first. And it's when they saturate that they will trickle down to the poor. And the richest are getting their intervention first. It widens the gap. Let's not say that we are going to talk dispassionately because politics matters, right? Somebody thought about this and brought it up, right? So it is going to inure to people saying that, oh, we're poorer, we are not able to access the services. It affects the idea. But it's not because it's being poorly implemented. It's just because there are these leakage systems that are enriching fewer people at the expense of the greater masses. So I think that thinking should also look at how we sustain the basket and make sure that the leakages are being blocked. But I'll have to add to the discussion.
Okay, Prof. So since we know about this, why did it take us this long? I mean, to detect all this in the system and correct it?
Unfortunately, we haven't detected all of them yet. Unfortunately, we haven't.
More.
There's so much more that is there because, look, I love the thought about going into implementation research around these. We should be able to know where these risky purchases are coming from. We should be able to know when these risky purchases are coming from. Look, I was on social media and I saw some streaks that people were doing on Snap. And I was asking myself, what does it mean? Not knowing the Stars jersey is selling for 1,599 cedis. 1,599 cedis. Because we are in the World Cup. The question you ask yourself is, it happened during COVID that people were selling for 100 cedis, a single mask for 50 cedis. Why are we like that? Right? One person's benefit would put the whole community at risk of COVID. And when I die, you will die with me. And so sometimes we haven't all the holes. There are simple ways. And unfortunately, we have outlived the days that we would have control prices. I get really worried about the thinking of the Ghanaian. And I would continually say that academia, we must come in with this high level of integrity and let people see that when we are speaking the truth. And that is why I always concerned about the students we are training. What sort of integrity, what sort of ethical standards are infusing in the children, in the students we are training? And are they able to stand for the truth all the time? So we haven't unplugged all of them. In fact, we haven't heard of what the problem is. Because there are some that we don't even know about, and it's only research that will unearth some of them. There are ghost facilities in Ghana. Now, we've talked about ghost names on the payroll, but there are ghost facilities that are receiving reimbursement from the National Health Insurance Scheme. So there is so much that we can do. And I don't know. I don't have the solutions, but I can only blab around it.
So researchers, over to us. It means that academia has to really come in so strong, do the research, and unearth all these things you are talking about. Now, Prof. Ayanori, you talked about protecting the vulnerables. I know if somebody who is a heavy drinker or smoker is listening to you and is hearing that we should put more taxes, you know, on these commodities so that we are able to fund health locally. What would be the reaction? Are we really thinking of some kind of remedies we can put in place for these people?
Well, just like Professor Menu said, if in the season of football people can sell jerseys at that cost, it means that there are certain behavior patterns that we must all learn to undo in the process of nation building. So if you fall within that category, and unfortunately you have to pay more in terms of sin taxes that Professor Asian has spoken about, you have to. Now in health, we have what we call moral hazard. So, I mean, the healthcare system can take care of your health needs, but your health behavior to a larger extent also determines how much public funds can be spent to take care of you. We say health is a public good because the existence of the health system is to ensure that there's equity and everybody's healthcare needs are met at all times. But it cannot be at the expense of the broader and larger population. You understand? So even though I don't have a direct question to you, but my answer is that our health behaviors, whilst we are talking about sustainable health financing, we should be able to build a strong advocacy arm as part of our primary healthcare objectives that is being rolled out to promote health. And the health promotion angle must strongly advocate for a strong behavior shift that would help us to be able to also bring down our health bill. Actually, if we are able to address some of the key health promotional issues, behavior change intervention issues, we could bring our health bill drastically between 2 and 5% down in terms of the spending on health. So that is very critical. So yes, health behaviors remain fundamental in identifying the barriers to financing health and then also being able to reduce our bill on health in the long term. So that's what I can add. Yeah, thank you.
Thank you. Yes, so we now know the sustainable mechanism. I mean, you mentioned making sure we tag health insurance to, maybe you want to renew your driving license if these things are made mandatory. And like you Dr. Dalaba said, in some countries, these things are tied to even getting admissions. And I think that will show the level of seriousness we are putting on it. Now, finally, I would like to come to all of you as we round up. What specific policy reforms should Ghana prioritize over the next 5 years to strengthen financing, procurement, supply chain management, and accountability for primary healthcare commodities? What will be the specific health reforms in the next 5 years? Yes, I'll start with Professor.
Thank you. So for me, the first one should be the reform on the sin taxes. Just recently, we reviewed the data where we're seeing a lot of childhood obesity, and we're seeing even young people developing diabetes at a very tender age, and it's worrying. So if we're going to go into preventive health, then the first policy we should target is to reduce the consumption of some of these things. If we increase taxes and it would deter people, we should do that, because we would end up solving the problem even before it begins. So my first policy take would be on introducing these things and deterring people. From our children to even all of us in this room, we spend a lot of time sitting. Our children begin to go to school, and it is the processed foods. We've not even thought about increasing taxes on processed food. which should be something we should really consider. And so by age 10, 12, they're already obese, they're already developing pre-diabetic symptoms and things like that. I think that is where our focus should be, so that we can enhance the preventive aspect of the primary healthcare agenda. Thank you.
Thank you. So who is to do this increase?
The policymakers are here. I mean, we're all here. So we talk about it. We don't leave it here. We set the agenda. We should have these discussions openly, you know. Can we have the morning shows across the country just for a week talk about this? It will cut the attention of the policymaker to say that, look, this has become a national issue. Can we deal with it? If we spend time talk about, the unnecessary stuff we hear every morning on radio, you know, some of the discussions we see on our airwaves and things like that. Can we dedicate, let's say, a week to talk about preventive health and the introduction of some of these taxes? The policymakers are here, all the academics are here, all the researchers are here. Can we all go on radio and TV to talk about it, to talk about the need for us to introduce that and set the agenda? The politicians will take it up. What they don't want is for them to develop the policy. If it is coming from us, if it's coming from the public, they are more likely to lean towards it. Because remember, the policymaker is thinking about the next election, the next vote. And so things that would introduce certain levels of hardship, they wouldn't do. But if it comes from the public, if the agenda is set the right way, they are likely to pay attention and they are likely to go for it. So it begins with all of us in this room. The conversations should start. It shouldn't end here. When we go to our various institutions, can we decide and say that once every month we'll have a conversation on preventive health? Look at some of these things. Let's reduce our sugar intake. Alex recently mentioned something about even treatment for diabetes, for hypertension, the cost. And if you sit back and you look at how much we spend to treat some of those conditions, and you ask yourself, if we had done the right thing by stopping or trying to let people know that, look, if you don't go through this lifestyle, you're not likely to end up here. If we're able to do some of those things, it will be very helpful. And I think all of us in this room should be committed to that. Thank you.
Thank you. Okay, so Prof, we know that the way to go, the first policy reform, if we are talking about policy reform in the next 5 years, is to increase taxes on some of these commodities that he mentioned. Any other policy reform we should be thinking about in the next 5 years?
Okay, so health is politics. We talk about health diplomacy now across the globe, but fundamentally, health is politics. Every health decision that has transitioned this country beyond where we started was a political decision, strong political decision and will. And I think that in the next 5 years is the same health politics that will transition if we need to make some fundamental changes to our health system. So based on all the discussions that is coming up, I think that strong structural reforms in the new programs and interventions that are coming up, the Ghana Medical Trust Fund must be strongly and fundamentally grounded for it to survive. Otherwise, it will not go beyond a political cycle if there's change of government. And it must be based on a genuine commitment by all of us to see that our health is transitioning and we need to take chronic care seriously. We need to look at new funding models in which we can look into the future of that fund. Beyond the threshold of money from NHIS that is allocated to the fund, in the next 5 years, there must be strong political and civil society reforms that can push for greater funding for that fund if we are to transition it into a fund that goes beyond a political cycle. Then within the Ministry of Health, there should be that strong advocacy for improving monitoring and evaluation systems. Monitoring and evaluation to ensure that the funding that we are raising, we are spending it the right way, as I've already said. And we are accounting for it, not just to the donors who provide that funding, but to us as citizens who also fund the health through taxation and other local means. So that is also very, very critical. I think we also have a very good outlook if the primary health care that we are advocating today is succeeds. And the outlook must be from both the provider and the user. So all of us as patients or users, together with providers. And lastly, for us as academics who are in this room, we must, within the shortest possible time, also be eager to generate some new evidence to support Ghana's long-term drive to sustain health in a very more equitable way. I think that there is some evidence that we don't have that is lacking. Okay. So all of us can begin to collaborate and to see what partnerships can we forge together so that these decisions that we are going to generate locally can inform how the policymaker takes that phrase of health is politics seriously, because if we don't generate that, they will still do the politics anyway. Health will still be a key feature. But the question is, the decisions that are emanating from this to guide us, are they based on the evidence that we as academics are leading, or they are just political decisions that are made at every political cycle because of getting electoral votes? So we have a lot of work to do as academicians and as we move beyond here. Thank you.
Okay. Yeah, so for the sake of time, talking about continuity, something I would have wished to ask, because most of the time once, like we have the medical trust fund, once there's a change in the event of change of government, then somebody comes with a new policy. I think these are also things we may want to, but I want you to give you your final words, because I've been prompted that we are out of time. Yeah.
All right. So thank you so much. For me, the policy, I will still stick on my issue that there should be a policy regarding school registration, regarding DVL registration, regarding employment. Okay. If that policy comes, any new employee, before they accept you to start work, you must show your health insurance card. There should be a policy before you register as a student, you must show your health insurance card. So these are the policies that I think if it's put in place, it will be fine. The next policy I'll also go for is tax, but it should be targeted one. I would go for mobile taxing or fuel taxing. You know, the e-levy that was introduced, within 1 year, they were able to raise, just 1%, they were able to raise about 1.2 billion, 1 year. So, but the unfortunate thing that why we had backlash was that there was no education, there was no consensus among the public. If you want to introduce tax and we open it, dialogue, and we say we are introducing tax 1% to help so that we'll move off paying premium, but it will be free. This will cover X, Y, Z. You dialogue well, I'm sure people will buy into it. And especially if the National Health Insurance is able to come out and say, look, this is what can be spent, a strategic plan. With this percentage, we'll be able to cover X, Y, Z. So what we are advocating for, this percentage will be able to cover this deficit that we are struggling for. If that one comes clear, I'm sure the public will absorb it. So I believe taxation in what we consume more will help a lot. Fuel or the mobile money. Thank you.
Thank you. Prof. Meno, your final words.
I just want to say again that, like everybody said, they've told us all the policies we need. But I would drive towards evidence-based decision making. And evidence-based decision making means that everything that we do should be backed by evidence. And there should be a policy that would require that anything we do should have a policy backing. The truth is that the politician, I learned very recently that the politician would not have evidence for the proclamations they make on their campaign platform. But the role of we, the academicians, is for us to shape that and fit it into a workable, sustainable solution. Free primary healthcare came as a platform promise. But look at the discussions and the discourse we are having around it. Nobody is saying, criticizing the policy. Now what we are doing is looking at making it work and work for the Ghanaian. If as academicians would also have that paradigm shift and to not always expect the politician to use evidence to make their promises, but that we should rethink and we support their promises with evidence on how we can make it work, I think we'll be on their good books, and for that matter, we would have success. So I think that we need to have a paradigm shift, and I think that if we have accountability systems built around technology so that we remove the human interface in most of the things we do, and there's a clear policy guidelines on that, it will make a difference. If I'm in Kintampo and you have a small shed, and that is where we come for clinic, and suddenly NHIS comes, and you build a 3-story building health facility, and you're asking me to come and pay again from my poverty to fund somebody's lifestyle, I would not want to do it. So I think we need to think at that level.
Wow, thank you so much. It has been very interactive. You've given us your solutions for financing primary health care, you know, in the face of dwindling external sources of funding. And I believe that, like the VC said in the morning, it should not just be a talk. We all know what to do. We have to go and do the research. We need to bring out the evidence so that our policymakers can, based on that, and bring out some of these policies that we are proposing. Thank you so much.
Thank you, Dr. Pearl and the team. Let's give it up for them one more time. Thank you. All right. So, is Prof. Gilbert around and ready? Okay. So, Professor Gilbert Abiru is an associate professor of health economics and policy and the vice dean of School of Public Health for University for Developmental Studies, Tamale, Ghana. He also a PhD in public health from the University of Heidelberg, Germany, and a master of public health in health economics from the University of Cape Town, South Africa. He has published 54 articles in renowned public health journals on various topics related to healthcare financing, health system reforms, and universal health coverage, social protection, and maternal, adolescent, and child health. As well, Professor Abiru has recently received research funding from a number of organizations, including the Medical Research Council, MRC, of the United Kingdom, Gavi, the Vaccine Alliance, the German Alliance for Global Health Research, and the Canadian Institute of Health Research, the African Studies Center of the University of Michigan, among others. He has also consulted for both local and international organizations such as the USAID, WHO, GIZ, Save Ghana, and the others. Professor Abiru currently serves as a member of the Governing Council of the Bolgatanga Technical University and a member of the Humanities and Social Science Technical Committee of the Ghana National Research Fund. Ladies and gentlemen, help me welcome Professor Gilbert Abiru. Thank you. Oh, Prof. Yes. Oh, sorry. Sorry for that. You're welcome. All right.
All right. About 10 minutes. All right. So thank you very much. And sorry for that. I wasn't the one who was supposed to present. So but when they called on me, I said no, I need to go and then free myself and come. But I'm fine. Okay. Thank you very much. So I've already been introduced, and the topic I'm supposed to speak on is innovative financing for universal health coverage, lessons from various contexts. When I was preparing for this topic to make this presentation, the evidence I came across, I said to myself, it would have been easier for me to present on what lessons, what innovative things that have happened in Ghana and other countries can learn from, because there's a lot that Ghana has done. So it was very difficult to say, okay, these are the clear examples from this country that Ghana is to learn, but at least I went through to prepare, identify what others are doing, and I'm trying to pick out some of the things that we can discuss. And when I listened to the National Insurance Deputy CEO, after his presentation, I realized that he has touched on a number of things that I probably will have to talk about. So I will still highlight them for the purpose of our discussion. And it's also built on Professor Yanore's presentation. He put up a lot of concepts and whatever. So I will try not to explain those concepts again, but just to draw your attention to some issues that we can build on. So this is a presentation outline. I want to put the presentation in context, look at the role of healthcare financing within universal health coverage, and what do we have to focus on if we are moving towards universal health coverage. Then we'll look at the concept and principles of innovative healthcare financing. Martin touched on this. Now I'll still build on it. What are the things that you need to look at when you're talking about innovative or healthcare financing? We have the traditional models that are there, and then we also have the innovative models, and what are available that we can pick out from. Then we'll look at Ghana, although Ghana is doing very well, but what are some of the things that we can still pick from other contexts, and how do we implement them in a more innovative way to ensure that our system is even more better than what is there. So that is the outline of the presentation that I'm going to look at. This diagram is very popular, and it's like almost every presentation that appears. So, but what I want you to pick out from here is that if you look at the diagram, it's all about universal coverage. What do we cover? We cover services, we cover population, and we cover cost. And Martin mentioned that we need 100% coverage. And when you listen to the chief executive officer, the deputy, he actually mentioned in terms of population, we are currently at 66, isn't it? Then in terms of services, we said 95%, but we are adding on more and all that. Then in terms of cost, you remember he said, but public funding is around 67. It's not, if you even add donor, it's not up to 70. So that there's still a substantial part of healthcare that is funded out of pocket in Ghana. So what do we need to do in terms of universal coverage? We need to expand the cube. And how do we expand it? We expand it by trying to raise more public revenue, because it's all about public revenue. So, and Cartism provided a framework for us to say that if you want to finance healthcare, look at these three first things: revenue mobilization, fund pooling, and all that. So I am making a point that if you are talking of innovation in terms of healthcare financing, the innovation will definitely be related to what? How do you raise the revenue? How do you pool the funds and the risk? And then how do you purchase the services? So this will be the framework for my presentation. I look at them in line with this. And I try to point out what other countries have done, and then what can we also discuss in Ghana and to bring on board. Now, Martin touched on this, but when I was making my presentation, I didn't see his I didn't see his slide, so it will still be there. But the point we need to pick is that when you say innovative financing, it simply means that you are bringing in something new or something that is not traditional, or you are using a traditional method in an adaptive way. So it's something new, or non-traditional, or adaptation of the traditional way of raising the money, pooling the funds, or what? Purchasing the services. And why do we need that? We need innovation now, not the traditional way. We need innovation now because if you look at the literature, every time we are talking about what? Limited physical space. So once there's limited physical space, we need to be innovative in order to expand physical space. We're talking about predictability. So you have this funding here, the following day, then there's no money. How do we ensure that funding is what? Sustainable, we can predict and know this is it. Then we are now talking about what? Purchasing the right services. It's not about getting the money, but how do we purchase the right services? So this will be the focus of what we need to think about innovatively. Now, if you look at, when I go through all the models that have been proposed as innovative models, which I will show to you in the next slides, I see that when you say something is innovative, what actually often happens is that the model tries to shift payment from out-of-pocket to that of what? Prepaid system. I've never seen any model say, oh, this is innovative, but then they're encouraging people to pay out-of-pocket. So once there is innovation, we are talking about innovation, out-of-pocket is what? Something we don't talk about. It's gone. Another one I have seen is that it's all about what? Increasing physical space. In the short term, how do we get the money? And in the long term, how do we sustain what? That money. And the focus is more on what? Mandatory systems. And when I listen to Dr. Lalaba talk about the fact that we say it is compulsory, how do we ensure it is compulsory? You don't want it to be voluntary, that people can opt out. So when it is innovation, what can you do to make sure the system is what? Mandatory. And then the focus is also on not allowing different pockets of what? Funding sources, but how do we fuse the traditional sources? Integration of what? Different sources. And this is very important. When you look at the innovations, they are often not introduced to replace the traditional systems. They are introduced to complement or to supplement. And then we discuss this, so I won't hammer on it again, but I'll come back to it and for the purpose of Ghana. Now, also, the innovation that we are seeing now, there is often incorporation of what? Digital technology, even digital technology in revenue mobilization, in pooling, and in what? Purchasing. And the focus, which this is very important, the focus is on value for money. It is not just about paying for the services. Do you get value for the payment you are making? And efficiency, I've already been spoken about, and there is equity issues. And the last one, also important. You know, the public sector has overstretched itself. Innovation simply means also trying to bring in what? The private sector. How do we get money from what? The private sector. All right. So these are the things that I looked up as what? Innovative, and then see what other countries are doing. Now I can bring that forward. All right. So this is just a slide I'm not looking at in terms of revenue mobilization. What are the traditional sources of mobilizing revenue that we have? And we all know, out of pocket, which we don't even like, we have tax revenue, we have insurance, and we have donor grants. Whatever it is around what? These sources. That's where we get the money from. But then, if you look at those countries that have decided to be innovative, what are the things that are making them innovative? They are looking for additional, new ways of bringing in what? Money. And you already spoke about airline tickets. And I will tell you a number of countries that are doing that. Then you have bonds. We have social bonds, social development bonds. You have vaccine bonds, among others. We'll look at that. Then there's digital technology. We can also do that. Then the financial transaction tax. That is one. The other way is that you take what you already have, a traditional source of what? Revenue mobilization. You are not saying bring in new source, but you have to earmark a proportion of it for health. So you can say, okay, all the money that's collected in Ghana, 5% of it is for healthcare. It is the same source, but we now know that this amount is going for what? Healthcare. And that's why the CEO, when he was talking, he mentioned about Abuja declaration of 15%. That is already a benchmark for what? Earmarking expenditure for what? Health in Ghana, in various countries. But we don't do that. But you can agree that, okay, we are not bringing anything new, but what we already have, then this is the percentage we will use. Now, blending. I already spoke about that. Blending, one source is not enough, so get from different sources. And there is this thing I want to emphasize because of the purpose of Ghana. You know, it is difficult to get premiums from salaries. in what? In informal sectors, where like in low and middle income country where you have only few people who are employed in the formal sector. So I will look at what is, in terms of Ghana, what is the possibility? Are we able to get salary-based premiums and then send taxes, which have already been mentioned? So these are some of the things that I have seen as innovations, and I will see which countries that are working on that going forward. Now, in terms of pooling, the traditional approach has always been a tax pool, which is like a national pool. Everybody contributes to that. Then you can now pay into consolidated fund and reallocate. Then, or it's an occupational level pooling. So you have, like, for example, a social health insurance scheme where it's for only formal sector workers. There's no that kind of mixture of the pools. Or you have a community-based self-pooling. The problem with this is that there's always fragmentation. And sometimes it's difficult to cover everybody. But what are the innovations that we are seeing now? The innovation in those countries that will say this is very innovative. You say there's a fusion of the various pools. You already have pools that are there, but they are merged together into one national pool. And Ghana did that very well. Then there are also complementary pools. Ghana will also look at that. So you have the existing pool, then you have other pools that are there to supplement. There are other top-up pools, or there are pools that are aimed at what you call filling gaps. Then we have also even digital pooling systems, where you just have a mobile money account and people contribute to that. It is done in other countries. And we are now moving towards more collaborations, not just multi-sector, but also cross-border pooling. And these have been championed by the regional blocks. You have the SADA and all those blocks have that, and I'll highlight on that. Now, in terms of purchasing approaches, what are the innovations we are seeing? So these are the traditional ways. And these traditional ways pay inputs. What you put in, you just get that. But now those countries that we are talking innovation, they move away from paying for inputs to pay for what? Resource. And when you are paying for resource, the two concepts that we can think out immediately is capitation and what? Performance-based financing. These have some kind of value. Capitation is more of population-based, but then it is better than what? All the other ones. Now, there are also a mixture of what? Different payment systems. But when you look at those countries that are even doing well, in the mixture, you still see capitation or you see results-based financing. And there are points that are countries that are doing very well. Then there are also electronic fraud detection systems. We mentioned that. I think Ghana started doing something like clinical auditing and all those checkups and whatever. And the whole concept of pooling strategically is what is now called innovation. So this is the framework from which I'm looking at. Now, what I'm going to do next is to just take you through this mechanism, which context has it been implemented, then we can pick it from there. And I'm still going by the Cartesian framework that we looked at. The first one is airline ticket solidarity levy. You know, if you look at a number of countries, we have African countries, I have a list of them that are there. About over 30 countries have introduced this. And it's not much, but $1 to $2 for economy class, and then $10 to $40 for business class. And it's actually like when you are buying a ticket to leave the country, then they add it and you pay. And it's a lot of money that is coming in. And it's something that people are already used to. And our neighboring countries, our brothers, Chad, Kenya, Mozambique, and Nigeria are also planning to do same. Though it's not currently being implemented there, but they are planning to do same. Is it not something Ghana can think about? That is something that I think I want to flag for us to discuss. How do we do it, and what can we learn from these countries? It is actually more, there's coordination in it. It's coordinated by what? UNITAD. But the thing is that if you look at it, these are more, if you look at what is happening, it's more used to finance specific services, such as HIV/AIDS treatment, among others. But it can be expanded. You can use it for any other way you want to finance your healthcare. So that is one. Then somebody also mentions bonds. And we have different types of bonds. You know, Gavi actually relies on vaccine bonds to finance vaccines. But we have government health bonds, whereby a government wanting to do a particular thing, you know, Ghana, we are used to bonds, and we know bonds. So we can actually raise the bond and just to collect the money to finance that particular activity. Then at the end, the resources that are coming out from there can be used to pay the bond. So if you want to build a teaching hospital, a new teaching hospital, then we can get a hospital bond and it can come out. These have been done in India. They have what is called health and wellness center bond. Kenya have infrastructure bond, and even USA has hospital revenue bond. But then that bond is paid back using the proceeds that are coming out from it. But what is also very interesting and innovative is what is called social impact or development bonds. What is interesting about this is that you get a private entrepreneur who can actually finance the service and ensure that there's resource. A donor or the government only pays for it when the resource is what? Shown. So you don't lose anything. The risk is that we look at a private body to do it. It started in South Africa, but it has spread to many other places across. But it's more often for something specific. Now, I won't talk a lot about this. The digital mobile pooling. So Ghana, already we have our NHIS renewal system. Then we have Kenya, India, and Nigeria also have different ways of using mobile technology. And some is even for saving, others even use it for purchasing. And but most often it can even be used, India, for example, to verify your status and then to pay up. All right. Then we have financial tax. And what I want to emphasize here, there are a number of countries that actually have tax on financial transactions. But what is evident is that they have not been clearly earmarked for what? The health sector. The only example I saw is in Kenya. They proposed in 2023 to earmark bank transfers. Okay. To earmark bank transfers for what? Health. But there was a lot of political resistance. It is not off the agenda. It is also not in the document. So they are still debating it. But that, of course, these are things that, will bring out this. Now, the other examples we need to know is about the earmarking traditional sources, what we already know. And it takes two forms, either the general revenue you earmark or in the form of sin taxes that you already have discussed. So we have example in Zimbabwe. Zimbabwe has what? 3% HIV/AIDS levy. And it generates about 50% of all the funds that is used to finance what? HIV/AIDS treatment in Zimbabwe. I know it's also similar to the Ghana 2.5 levy. But this require what? Law. You have law, you need law and then political commitment. Now, Martin and the other group spoke a lot about public health taxes, which are called sin taxes and all that. And this cut across a number of countries. Colombia, 4% of VAT on mobile phone. Then you have Botswana, which are started, as an example, you have an alcohol tax. They started with 30%, and as of now, as of January 2015, 15% of the value of alcohol you consume in terms of money goes in there. And the president had a belief that it is alcohol that was one of the causes of HIV/AIDS transmission. So it is actually for what? HIV/AIDS treatment, Thailand and co. What we need to emphasize is that it is not necessarily you have to bring in a new sin tax. Some of these things are already taxed, but they have not been earmarked. You need to agree on what we are collecting on this sense. What percent of it is for health? So if you say 1%, then that is it. Okay, so that's the message that I want to give. Then in terms of blending, Martin spoke about that. We have blending in a number of countries. And I want to emphasize those countries that are often seen as doing very well in terms of what? Pooling with Ghana. They have done some form of blending. Ghana, Thailand, and Colombia have 3 major different sources. Then you have Rwanda that rely on domestic and that of what? Donor sources as well. And then even Nigeria, our neighbors, they have that kind of blend which we also have, combining both formal and that of what? Informal. But there's something I also wanted to pick up from. This salary base, this. I'm saying this because if you look at the discussion we have about Ghana, we say that we are getting money from the formal sector, isn't it? Through 2.5% what? Money from SNET. You get that? And we say that's the formal sector contribution. But indeed, is it a salary-based contribution? Is it all formal sector workers that are contributing? I can tell you all the lecturers that are here, don't pay that 2.5%. You get that? Do we have the opportunity to shift, even if we keep that, towards getting even 2.5% of what? Everybody's salary into the scheme. How much will you get? A lot. And I'll give you examples. For advanced Germany, about 14%. And you have the employer paying, and you also have what? The employee paying. Belgium has. But look at Asia, Japan. And I'll even count our own context. We have, look at Kenya. Kenya, they have 2.7%. But it's actually only the employee that is paying now. We have Nigeria. And I think Nigeria, though the scheme may have issues, but this is something they managed to get through. 11% of everybody's salary is deducted. Now look, the employee himself pays 1.5, and then the employer pays this. Ethiopia and all that. Ghana has 2.5%, but that is not a salary base. So my proposal is that we need to think about what? A salary. If we are committed, I am a lecturer, I'm a associate professor, my salary is bigger than the formal sector, but you don't take anything from my salary because I don't contribute to SNET. Is it equitable? Take it from there. Okay. Now, some of the things I'll jump. So the fusion too is also there. We have examples of countries that have done fusion, and we don't need, because Ghana, we have done it very well in Ghana in terms of what? Blending what? The different sources. Then, so that is in terms of innovation. So in terms of fusion, we have different schemes that are there. In terms of, I'll finish soon, in terms of digital pooling and all that, Ghana too, we have also done like other countries that we don't have a big problem there. In terms of they're still pooling, I want to go to purchasing. In terms of purchasing, one major thing that I have observed is that the concept of what? Supplementary pooling systems, which is to fill gaps. And we have a number of countries that have done that. But many of the countries, they have the main system, which is what? A public system, and they use private to what? To fill the gaps. But others also have additional public. And that's why when I listened to the NHIS man, I was so moved, because my fear was that having free primary health care, having a medical trust, and NHIS, how are we going to marry the two so that they don't become competitive, they don't become conflicting? But when you see the model he presented, I was happy. And my only fear is we should keep to that model, to know that these are complementing what each other. And that is very innovative. This is another innovation that Ghana is bringing up. But that's the framing that has been put in there. So I spoke about multi-country pooling. This is led by the regional blocks. So they're thinking about what? Having what do you call it? Regional-based schemes and all that. Then we have this one that I want to emphasize. You see these countries I've mentioned, Thailand and Rwanda. When you look at the literature, and they're talking innovative healthcare finance within low and middle income context, sometimes they will mention Ghana first, but you see Thailand, you see Rwanda. What is only unique about them that is not in Ghana is the purchasing part. For each of them, there is what? A value-based payment system. Either pay for performance, performance, or you pay using what? Capitation. And look at other countries that are doing well. When you see the mixture, you say there's capitation what? Somewhere in there. Are you okay with that? Conclusion, because I'm told I have 1 minute, because I was told I was supposed to present for 20 minutes, and he now told me 10 minutes. Exactly. So these are things I have flagged based on what I know about Ghana and what I've seen in the literature, that in terms of new sources, we already started discussing this. Can we consider syntax on alcohol and tobacco? Not just say we should introduce by earmark. Can we think about ethics for health? Can we introduce one? E-levy. And somebody mentioned this. I think that we missed an opportunity. When we were going to abolish the e-levy, we could have converted it to what? A health tax. And you know that the good thing about earmarking is that people know that the money is going to be used for this, and that they are more likely to accept. Betting tax, we kicked against it. If it was framed as for health, there was a possibility. Fuel tax, we mentioned these bonds and all that. Then in terms of revenue pooling, it's still revenue mobilization. I'm talking about thinking about what? Formal sector salary base. Can we, can UTAC agree that we are not paying? You understand? Because we are not Senate members. Take 2.5% of our salary to add, if we were committed to that. Anyway, then in terms of our mobile system, it's very good, but these things have been flagged. Sometimes you'll be there, then because you don't go to the office, you forget. So we have already spoken about how do you make it efficient. Can we have prompts, systems that are there? Is there a way to program that can take the automatic renewal? So anytime the time comes, then you renew it. Okay. Then the last one, which I already mentioned, is about what? Complementary. Let's make sure that we ensure that we actually implement those 3 systems that we have now in a very complementary manner. And we must take this carefully. I did some work on capitation that was introduced in Ashanti region. And my conclusion is that capitation didn't fail on technical grounds, but it failed on political grounds. So can we address the political dynamics and bring it back through whatever means we are going to do it, and then we pick it from there. Then the last one that we hammer on, and the chief already mentioned that they are exploring value-based payment for what? The primary health care they are talking about. And I can assure you that if you don't use value-based payment or population-based payment, the primary health care will not work. All those areas that are talking about primary healthcare as part of this, they go at capitation or they try to pay for performance, among others. So that is the simple message I have. Thank you very much.
Thank you. Let's give it up for Prof one more time. Sorry for pulling your legs. It's a punishment for not paying your 2.5 on the NHI loan. All right, thank you. So we will be taking our next presentation. We'll have someone joining us virtually. So yeah, I'm sure the IT is working on it. So let's use the opportunity to welcome Professor Amafeni, who is the Gavi consultant, giving us some presentations on findings from Gavi. So, IT, over to you. Thank you. Oh, we can clap for her. She'll hear us virtually. It's all right, that's fine.
So thank you. Can I be heard? Good afternoon, everyone. So I'm not getting any feedback that I can be heard.
We can hear you, so you are good to hold.
Okay.
You
Okay,
have
great.
13 minutes.
All right.
All right.
I have how many minutes?
13. Your time starts
13.
now. Yes,
Okay, I was
please.
given 20. All right, I'll try as much as possible to move as quickly to the slides. So this is an overview of what we've done so far, looking at Ghana's transition from Gavi support. Here, I'll just highlight some of the bottlenecks, some of the risks, some of the sustainable financing options that we have talked to. This engagement was in consultation with several partners over the past year. Ministry of Health, Ministry of Finance, Ghana Health Service, EPI, our development partners, civil society organizations, and private sector representatives. So the views that I share today are views from several stakeholders that we have engaged with over the past year. I'm not going to belabor this point, but we know that Ghana will fully transition from Gavi support by 2030. And already our co-financing obligations are going to increase between now and 2030. We also know that we will have to take decisions as these transitions happen. We are seeing that our resource envelope will expand as we introduce new vaccines into the system. So the question is, can we sustainably finance our vaccines and immunization operations after this transition? So I will highlight some of the findings we have come up with as we've gone along this journey. What have we done so far? We've mapped government and development partner financing for vaccines and essential health commodities. We've also quantified our financing needs and gaps. These have been shared with our civil society organizations for advocacy. We've also looked at donor transition risks. This includes the phase out of Gavi support by 2030. We've also completed a bottleneck analysis that covers PFM, budgeting, procurement, supply chain, coordination, governance challenges. I will highlight some of them today. We are currently undertaking a comprehensive operational costing of immunization in Ghana. And here we're including vaccine delivery, cold chain, logistics, surveillance, program management cost. This is still being worked on, and hopefully we'll be able to complete this as soon as possible. what we've done in this process is to establish a very strong evidence base to support our sustainable domestic financing efforts. We need to do this as the date for transition looms ahead of us. So we know that there are several sources for funding when it comes to immunization. We have currently we have flows from the Ministry of Finance budgets, releases, Ministry of Health allocations, NHIA statutory allocations. These are also layered with Gavi co-financing supports and other development partner contributions. So again, you can see that the funding that goes into the program comes from different sources. There have been some challenges. We've noticed concerns around delays in government funding releases, and also the limited predictability of financing flows. We've also seen that we do have a growing vaccine and co-financing cost that needs to be also looked at. And so when we talk to our stakeholders, these are issues they raised. They raised these issues around delaying of payments becoming more of a recurring issue. The fact that we don't have visible earmarked allocation for immunization, which leaves a lot of vulnerabilities around financing of our vaccines, especially when we do have fiscal pressures, okay? And the fact that we also are heavily dependent on our donors when it comes to issues around cold chain equipment, operational costs, capacity building, and these raise red flags. And so the road to the transition is not just about how do we raise money. There are several aspects of it that we need to also consider. We do have a transition plan in place. We have done this quite early on, and so the foundation really exists, but we need more momentum. Without accelerating this action, we will find that we become more reactive than strategic. And so we are encouraged, many of the stakeholders are encouraged by the fact that we are seeing more efforts to get more momentum to move along this transition period. I flag operational costs because this was an area that our stakeholders raised as key areas of challenges, and that quite often we are more concerned about the financing of the vaccines themselves without thinking about what it takes to actually drive the process. And so as part of this engagement, we need to really understand how much it costs us to not just procure vaccines, but also distribute vaccines and make sure that every child and every person who needs these vaccines has access to that. And that means we are looking beyond, we are looking at the operational costs. That looks at outreach, supervision, data systems, transport and fuel, vaccine distribution, cold chain maintenance and monitoring, and other activities that ensure that these delivery processes get done efficiently. So today we are carrying out this process, but then we know that a lot of these activities have been covered by Gavi CDS funding, Gavi HSS funding, and other donor mechanisms that have cushioned the system to this point. And we know for sure that these envelopes will shrink. And so the operational backbone is not just the vaccine procurement, but how to make sure that we resource the engine that carries the vaccines. And so that is what we have done, and we hope that this will feed into the roadmap transition planning and highlight the need to find more money domestically to support the system. Again, when we talk to our stakeholders, they identified about 4, and this is not comprehensive, but these are some of the areas they highlighted that we may risk having to look at our vaccine portfolio again if funding becomes an issue. There's also a chance of seeing some of diseases rebounding, potential resurgence of some diseases. Again, they raise issues around the cold chain failure becoming an issue if that is not maintained. And also the fact that there are likely, the likelihood of supply interruptions if this happens, especially with the delays in financing and also procurement roadblocks. We spoke to civil society. They assured us that they are moving everything to make sure that they will advocate. Currently, I know that they're making inroads when it comes to advocacy with Parliament, media engagement, today being one of them, right? Public awareness campaigns, engaging all stakeholders. And so they have positioned themselves to be politically visible between now and 2030 and beyond. For the private sector, and I'm happy that I heard the private sector mentioned today in one of the sections during the earlier presentations. For the private sector, what they say or their view is that they are already contributing in several ways through facility space, logistic supports, personnel, outreach infrastructure. They contribute, but the problem is we don't know how much this contribution is in terms of the value of this contribution. And so one of the areas where they suggested that it could be very helpful was to find a way to quantify private sector investments into this sector so that we could actually see their involvement and engagement in the space. They also talked about maybe a more formal engagement strategy, which could also unlock some tax incentives, co-investment opportunities, especially when it came to supply chain. They wanted to see more partnerships. And even for cold chain support, some of them were very agreeable to having engagements in this area to support our cold chain. And so the private sector is more than willing to be part of this engagement as we transition. And so I think 3 months ago, maybe 4 months ago, we had engagements with CSOs and also some of our partners to look at how we can create some strategy around making sure that we do have funds available for vaccines and operational costs. And so again, I know that it's not in our current dispensation to create separate funds. Nobody has an appetite for separate funds. But we do have the opportunity to introduce visible budget allocations within the Ministry of Health budget, for example. And so the suggestions as we have deliberated along those lines is to find a way of, and I know that we already have a global fund earmarked funding baskets for this, but then to clearly make it visible for immunization programs and all the operations around us, we suggested have a line for program commodities and vaccines, and then program operational funds. And so what this will do is that it creates the visibility, the transparency, and also parliamentary oversight, and protects this fund or this line in the budget to ensure that when Gavi transitions, we will still have resources to cover both the cost of vaccines and also the operational costs for moving the vaccines along. So this is how it would look like. So one ministry budget, but two visible lines for safeguarding or making sure that we can see clearly and visibly these programmatic funding lines. So as I'm just wrapping up with this presentation, there are a lot of areas where we are still working and still engaging with our partners to do between now and the transition period. And when the transition period ends, issues around funding gap analysis, that's still ongoing. We are hoping that we can move all the work we've done into the National Immunization Strategy Plan in terms of vaccine forecasting, aligning the operational costing into one view so that when you pick up the National Immunization Strategy Plan, you actually have all these inputs in there. And again, CSOs have assured us that they will continue to pursue budget advocacy, and that is something we are very, very happy about. We also want to see, and this is from the stakeholders we've engaged with, they want to see high-level political engagement. And I'm happy that this has come up in previous deliberations today, that we need to see a lot of political push behind all these strategies to ensure that it becomes a reality. Again, the transition the transition roadmap is gaining momentum. We are hoping that as we continue to create this awareness and to bring all this evidence to play, it will definitely make a difference. So as I wrap up, the question is no longer whether we will finance immunization after Gavi transition. We've gone beyond that. Okay, it's whether the country will put the necessary financing, governance, and accountability mechanisms in place before 2030. We do have a window for us to continue to engage and make all the efforts to make this happen. But every year we delay the process, is every year we lose the chance to build this momentum. So we need to act now. We need to be able to put together a sustainable foundation which ties into the goals of the pre-primary healthcare agenda as we have it. So thank you very much for listening to me, and I hope I made the time. Thank you.
Prof, you've done well with the time, and I appreciate that. It seems you pay your taxes. That's good. So our next presentation is also virtual. So while he prepares, I would take my time to go through his profile, and I'm sure if Prof. Justice could hear me. Our next presentation is from Professor Justice Novinon. Professor Justice is the Technical Director for Health Economics and Financing at Management Sciences for Health and Professor at the University of Ghana School of Public Health. He is a distinguished health economist whose work spans health financing, economic evaluation, health technology assessment, health system strengthening, and health policy across Africa. At the University of Ghana, he teaches health economics, health systems leadership, and evaluation and health policy. While supervising undergraduate and postgraduate students, his research and consultancy experience extend across Ghana and several African countries, including Botswana, Malawi, and Nigeria. He has led and contributed to numerous projects funded by organizations such as WHO TDL, WHO African Regional Office, GSK Vaccines, Danida, worked through the African Population and Health Research Center, the African Economic Research Consortium, the World Bank, UNICEF, FAT, DFED, and the USAID. Professor Novinon currently serves as chair of the Global Evaluation and Monitoring Network for Health, co-chair of Ghana's Ministry of Health Technology Assessment Technical Working Group, and vice chair of the Health Economics Unit Technical Advisory Group of the African Center for Disease Control and Prevention. He also serves as associate editor of BMC Health Disease Control and BMC Health Research Services. As an internationally recognized scholar, Professor Justice has published extensively in peer-reviewed journals and holds several global and academic appointments affiliations. His expertise in health financing, economic and evaluation and policy analysis makes him a leading voice in discussion on the sustainable financing for primary health care and universal health coverage in Africa. He will be presenting on the examining immunization financing models and their impact on immunization programs and health security in Ghana. So, Prof, if you are ready, we are ready to go. Thank you. Let's give it up for him whilst he prepares to come on. All right.
Can you hear me?
Yes, Prof. Loud and clear.
Can you see my screen? But could you please remind me how much time I have?
10 minutes. 13 minutes.
I have what? 13 minutes?
No. So I've been asked to give you 20 minutes, but if you can do it in 15, God will bless you. All right.
I was told 30 minutes. So if you'd say 20
Thank you.
minutes, that's okay. I can stop wherever I get, provided I make my point. But unfortunately, I cannot see the audience in the room, but I acknowledge all the dignitaries and senior colleagues gathered in the room to discuss such an important topic. I also acknowledge colleagues online. I have tweaked my title a bit, and this is what I'm going to speak about: sustainable immunization financing towards Ghana's health security. And I hope that this, captures what the organizers had in mind. I will focus on these areas in my talk, and please feel free to let me know if I cut off or you cannot hear me or you cannot see my screen. So I do not want to belabor the point because I think this has come up a lot today, that vaccines, immunizations, vaccines themselves are not, but immunization, that is getting the jab into the arms of people or, into the human body, are impactful public health interventions. The recent report by WHO estimates that more than 100 million infants have been saved since the expanded program on immunization started in 1974. And since 2000, when we've had a lot of progress in countries, in part mainly due to the establishment of Gavi, 36 million lives, infant lives, have been saved. Vaccination also generates high economic returns, and the evidence is clear on this, that for every $1 invested in immunization, returns of between 19.8 and $52.2. And this is between 2011 and 2030. Of course, this is a range, but it depends on what specific approach was used in estimating, the costs and the returns. So we know that they are very impactful interventions. This screen is very small, and it's intentional that you don't see, but simply to let you know that when it comes to Ghana, immunization has been shown to be cost effective, even for the more expensive vaccines, such as HPV, which Ghana delayed introducing until not long ago. These have been shown to, yield high value for money for any society. So the evidence you have here are various studies that we've conducted, ranging from, malaria vaccine RTSS to rotavirus vaccines under very different scenario, initial introduction and the switch of the vaccine, to HPV vaccination, to COVID-19 in Ghana. These have shown to be cost effective. So the evidence doesn't lie. It's clear that there's high economic impact of vaccines. You may have seen this slide already, but this is something that came up, I think, a couple of days ago, maybe yesterday or a couple of days ago this week. This is not Ghana. This is in England. This is a BBC News report based on a Lancet publication that has just been released. That in England, so this study followed a cohort of girls who were vaccinated between 12 and 30. And another cohort, really, to assess the impact of the vaccines, HPV vaccines, on deaths due to cervical cancer in the UK. And you can see the bottom here, that between 2020 and 2024, UK recorded no case of cervical cancer in that cohort. This is good news for everybody, and this should be that even for vaccines that are a little bit more expensive than the other ones, we can show that these work, and this makes a strong case for every country to take up, not simply using other people's money to implement vaccination programs, but actually actively using your own money. Using your own money brings me to the point of discussing the current state of financing health and vaccines in Africa. I won't spend a lot of time on this, but this is a study that we published a couple of years ago, not long ago. This has been cited quite a bit. But bottom line for this slide is that aid contributes to on average 20%, a fifth of health spending, but there's significant variation across countries in Africa. Some as high as 50, 60% depend on aid to finance the health systems. This slide shows you the top 20 recipients of aid in Africa. And as you can see, by source, domestic public financing remains a fairly small source. This is largely, of course, because it's its top 20 donors, it remains largely aid, but also out-of-pocket payments. What we want to do is to shrink green and red and expand the blue, because that's more sustainable. How is Africa doing in terms of domestic financing for health? Not as much as we promised to. In 2015, exactly 25 years, 2001, exactly 25 years ago, the heads of state of all the member states of the African Union met in Abuja in April and committed to 15% of annual allocations, budgetary allocations to health. The average now is about 7%. This is based on a bit dated, WHO Afro data. But bottom line, we are not doing good in terms of domestic financing. And I will return to this topic in a bit. Going back to vaccines, I think as Prof. Feni and Prof. Abiro have said, and others probably have said, Africa largely depends on Gavi and donors for financing vaccine. To the left, you have the list of diseases that are vaccine preventable. To the right, you have Gavi's work in Africa. They've spent, more than 15 billion since 2000. a little under 10% on average. Under 10% of that has come from country co-financing. So if you think about the rate at which we are transitioning, 10% is not good. But anyway, let's look to the future. This is what Gavi has done, but Gavi won't be the same going forward. So countries need to, rise up. There are threats to sustainability of, immunization in Africa due to various reasons: declining aid, the current geopolitical landscape, stagnating domestic financing, and I'll show you why there's a bit of worry for me in financing of immunizations in particular. This is the current state, at least as if the data I pulled from Gavi serves me right, of African countries and the various transition phases within Gavi. Ghana is at an accelerated transition phase, and like Prof. Feni and others have said, by 2030, we transition out. That means we take responsibility for 100% of all immunization, or vaccines. I mean, we already pay for immunization, the delivery itself, but in terms of the vaccines, we co-finance. So, what is the future of immunization in Africa? Immunization financing in Ghana. One cannot say that without realistically talking about the future of financing of health more broadly in Africa. And if we talk about the future of financing of health, the Abuja Declaration is very key. Okay. This is paper that is coming out, the joint analysis between University of Ghana, UNICEF, and MSH. What we did was to take the behavior of financing, public general government health expenditure over a number of years. So this is a time series data to map the behavior of health financing over since 2000. And we use that together with other economic indicators to project the future. So to the right, you would see my right. You'll see what the future shows. But bear in mind that the boundary of this graph is 7.5%. Okay?
Then go to whether you are up.
Okay, may I proceed? All right. So the boundary is 7.5%. The simple, message in this is that more than 75% of African Union member states are completely off track to meeting the 15% Abuja target by 2063. Completely off track. Where is Ghana? Most of these countries, including Ghana, have less than 1% chance of meeting the Abuja Declaration. That is, of course, if nothing is done. So we do have an option. We need to accelerate substantially domestic financing for us to get to meet this Abuja target. Otherwise, it will remain a long-term aspiration rather than a near-term outcome. So I'm not saying we can't. The issue is if we do nothing, if we sit and fold our arms, we would never meet this target, even in 50 years, beyond the 2063. And Ghana is one of them. So I wanted to paint this picture so that you see the landscape of financing health more broadly and the future of it. Now, the future of financing immunization is tied to this. So this is what I want to show you in this slide. There are two panels in this slide. The left panel takes time series data. This includes data for multiple years for all African countries, that have data, as we could source from the WHO expenditure database, to map the behavior of immunization financing from domestic resources across many years. And you can see that, this goes down. If you look at the curve here is not speaking so well for immunization. Immunization financing, spending on immunization from domestic resources actually going down. But if you look at, so that can be a bit troubling. But I want you to pay attention to what is happening to the right. What is happening on the right panel is actually mapping domestic financing for PHC with the Abuja target. Okay? So the left one is saying that as countries increase health financing from domestic resources towards the Abuja target, the proportion of that goes to immunization is going down. Now, the right one is saying that as countries increase, their level of domestic funding for health and gradually move towards the Abuja targets, the proportion of that money that goes to PHC is actually going up. So there's a positive relationship between PHC financing and the Abuja targets. Why is this distinction so? Now, PHC is a more systems intervention. This is one of the arguments we put forward. PHC is a more health systems level intervention. And therefore, governments tend to see PHC financing as a responsibility, even if the level of financing is so small. Immunization has been a vertical intervention, and many governments, as I will show in another slide, tend to believe that this is the responsibility of donors. So even if I have money, why do I commit that money? So what do you do if you want to increase immunization financing? Make sure it is visible and tied to PHC, because that's the only way to get governments to finance that. And there are constraints to what we see around the current state of financing. I've talked about, geopolitical landscape problems. We have our own fiscal constraints. There are also political economy issues. I won't dwell so much, but here, debt service is just one of the fiscal constraints we have. And the earlier we found solutions to that, the better it would be to free resources for other health. Again, here, what we do is to address the issue of transition, in domestic and donor financing, particularly in middle-income countries like Ghana, which typically tend to suffer because when there are transitions, people assume that because some indicator called GDP has gone up, you are better off to pay for yourself. But in real sense, you are not. We've shown in this that successful transitions from health aid are possible, but they require effective leadership and domestic resources, among other country systems. In this paper, what we did was to show, through collecting data from 6 African countries, that the political economy of financing immunization is also very important when we think about the future of financing, immunization. There are leadership politics, very high incentives, but low commitment to actually financing immunization and health commodities. There's budget politics, the power play between finance and health, budget execution problems, capacity of ministries of health to negotiate budget with finance, bureaucratic politics, external actor politics, lack of, the coordination, the extent of coordination of donors. These are all important factors that play out when it comes to financing of health in Ghana, in Africa more broadly. Now, on this slide, I will share with you just 3 of the models of health financing, 3 cases that have been shown to be successful. And I share with you the cases of India, Brazil, and Thailand. Now, India's model, focuses on domestic manufacturing of vaccines and self-sufficiency, starting with the introduction, the national health policy national policy in '86 that, made vaccine reliance an explicit goal within budget lines at federal and government levels. Now we know that India produces most of its own vaccines. Brazil is another, started way back in 1982 with a program, that built institutions that have become the backbone of the vaccine production industry. Now, Thailand, my good friend, Prof. Biro, talked about the Thailand, their UHC social insurance. Thailand has specifically built into that financing of APIs, and we can see, how Thailand is doing when it comes to self-sufficiency in financing or improvement in financing of immunizations. I want to spend a bit of time on this slide, which will be my last slide. Unfortunately, I've had to rush through this, but this show my own reflections from studying the data, from engaging with the people within the ministries of health, but also from engaging with ministries of finance, ministers of finance, economic advisors to presidents, and other high-level officials across multiple African countries from my time at Africa CDC, and also in engaging in Ghana's own systems. And I see 4 main hanging fruits for Ghana. One is that we have built a successful, well, still has challenges, but successful health insurance model. Not only that, we also initiated very boldly, key measures, which included free maternal care, the medical trust, the free PHC. If you think of this, these are very bold moves that successive governments have made, and I think that places Ghana, in the limelight. What we need to do is to fully and clearly embed immunization financing into free PHC. We cannot wait until 2030, and I'm happy about the work that Prof. Feni is doing. In designing the free PHC, I mean, there were conversations, and I'm not going to go into a bit of that, but we still have the thinking that, oh, there is someone at the door who is paying for immunization, for at least who is paying for the vaccines. So until we get there, let us allow them to pay for the vaccines. Until you start seeing your responsibility from today and taking measures today, you cannot really wait and get to 2030 and deal with it. That has been my point of view. And I think that until we clearly embed it now, we may be surprised in 2030. The political momentum towards local manufacturing, evidenced by the setup of the National Vaccine Institute is very commendable. I mean, it puts Ghana, it gives us the political backing to move this forward. And there are some critical pieces of work that are, being done by the Vaccine Institute. This initiative is important, but let's bear in mind that Ghana is not an island. And we probably, if we need to put up a successful or set up a successful local manufacturing industry, we probably cannot consume all the vaccines that we produce. Therefore, we need to make money from it also. And so we need to work towards economically sustaining manufacturing systems while leveraging regional markets. And for sustainability, markets are very important. The case of South Africa during COVID-19 is important to highlight here. Now, I also want to isolate the rhetoric versus the reality, what I call rhetoric versus reality. The political momentum on health sovereignty is great, and Ghana is doing a lot of work in that. But we must translate that into visible increases in new financing. Yes, efficiency is great, but we need to be clear about efficiency enhancing measures. Here, I'm talking about new financing. I'm only echoing the point that Prof. Abiro said. We cannot implement free PHC for 100% of the population without new financing coming in. Yes, I know that the capping of the NHIF has been great, but it will not be enough to implement everything. You cannot focus on decapping to support free PHC, to support the existing health insurance mechanism. You need to bring in new money. We need to earmark specific new or existing taxes. Prof. Abiro and I have been chatting about some of the taxes he put there, but we've had opportunities that I think we've blown, and very non-politically, beyond the tax that he highlighted. I think one tax that we actually have blown the opportunity to leverage is the COVID-19 levy, which we could have, put, more or less change the name and converted that into a free PHC levy. But let's not shy away from going back, because Sankofa is very important for us. We really need new money to come in. You cannot, 1.2 billion is not enough. It's only implementing free PHC for 150 districts. You cannot cover all districts without new money coming in. That's the point. The last point I want to make is that for donors and for the government, we need to reframe or rephrase what aid should and should not do. And for donors, it's important to be very targeted at what current aid will do, in terms of crowding in country leadership and ownership, in supporting domestic financing infrastructures, but not directly paying for commodities. So that's something we've written separately about. Government need to build and leverage the capacity of local institutions to drive supply of technical assistance and research to inform ideas. And here, let me highlight that I know there's subtle reliance on global North institutions for the ideas that drive state agenda, for the ideas that drive donor agenda and partner research. TA sourced from the global North cannot and will not build local capacity. One needs to make a decision to engage local capacity and develop local capacity to drive these ideas. That will expand, sustainability not only for the immunization, the future of immunization, but also for the free PHC program. I thank you for your attention, and over to you, MC.
All right, thank you so much. Let's give it up for Prof one more time. That was beautiful. Okay, thank you. So, as a way of maximizing time, we would be putting together the second and the third panel discussion as one. So we will do that concurrently with the two teams and the two moderators sitting side by side to get that done for us. And for those who will be joining online, I think they should be prompted so that they will be ready, and our questions too as well. For those of us who have questions during the panel discussions, we'll give a time for open forums, and those questions will be attended to. So without wasting much time, I'll invite the moderator, Professor Gifty Ampofo, and Dr. Vivian Taki to take up the seats and get the introductions there for us. Thank you.
All right, good afternoon, everyone. And we'll zoom into this discussion as soon as possible. So for members of the second panel, we have Prof. Ama Feni online. She's a consultant from Gavi. And we also have Dr. Selom Kuchuati, who is our EPI manager, to join us. She's also online. Then we have Mr. Fred Osei Sapong, our rep from WHO. Kindly take your seat here, thank you. And Prof. Essien. Oh, hi. Thank you so much for coming already. So, yes.
So for the other group, we have Prof. Gilbert Abiru, the Vice Dean of SPH UDS. And then Dr. Ajua Chumbarima, Health Financing Officer, WHO. Oh, okay. Okay, Professor Yete Anwame, KNUST. Yeah.
So, thank you very much. Prof. Ama Feni already mentioned some risks that could be associated with the transitioning of Ghana, of the Gavi support. So can we highlight these risks, again, the most significant ones, and then talk about how we can mitigate these risks as we round up these discussions. So our question is to highlight the most significant risks involved, financing risks involved with the immunization program, and how we can mitigate these risks. Yes, Prof. Amafeni, if you can hear me, you could please contribute to this. And then Mr. Fred,
so,
you can also
I think I highlighted the risk in my presentation. I don't know if I have to go back and project that. I could do that whilst you go around to the other
You'd like to project the risks?
I'll just go
to the risk. So then Mr. Fred would...
Okay, these were the 4 major risks, but this is what I highlighted as what our key stakeholders projected during our discussions.
Yeah, thank you very much. Maybe let me come in here. Good afternoon to all of you. My name is Fred Osei-Sapong, immunization focal point in the WHO country office. Yeah, so as was indicated in the presentation Prof. Feni made, all of us made contribution into it. So what she presented is not going to be any different from what I'm going to talk about. Yeah, so perhaps the most important risk is the vaccines. Without vaccines, there are no vaccinations. Yeah, so if we do not commit to make funding available for vaccines, we can never sustain the national immunization program. Beyond the vaccines, there are other major important aspects that we need to talk about. And as she clearly indicated, Ghana has a transition roadmap towards immunization self-financing. But the roadmap is heavy on vaccine procurement without much on how the vaccine is going to be delivered. So in the area of service delivery, surveillance, cold chain management, all these are some way, somehow not captured in the transition roadmap. But if you have vaccines, but you cannot sustain the cold chain, you do not have the equipment to keep the vaccine within the temperature range, of course you don't have vaccines because they are not going to be potent and they cannot be used for the intended purpose. Beyond the vaccines, there are also data quality issues. You build capacity. If you don't have the resources to train your core human resource, capacitate them to be able to deliver the vaccines, to document and then use evidence to improve on the quality of work you do, you cannot run an immunization program. So clearly, there are major risks that we really need to look at and get them addressed as we navigate towards the transition journey. And as was communicated, Ghana is on record or on track to transition from Gavi by 2030. But the transition has actually started. Ghana entered accelerated transition phase in 2022, and we are paying incremental amounts in terms of our commitment to Gavi. And by 2030, we will completely exit Gavi support. So the transition is not going to be 2030. It has actually started. And we really need to make commitment. We really need to advocate so that our immunization program is sustained. I'll pause here for others to come in. Thank you.
So if Prof. Feni can add on to this for us briefly, then we can move to the next. Yeah.
So I think Dr. Fred Sapong is very right. we can't overlook these issues. And I think one of the things that some of our stakeholders alerted us is the fact that we may have to start looking at vaccine portfolio reduction. So it's not just about the vaccine procurement, and I'm happy that Dr. Selom Kuswas is here and she can speak to these issues. The fact that we may have so much pressure to remove some of the selected vaccines from our schedule if our funding issues become a problem. That's an area that some of our stakeholders highlighted. Thanks, over.
Thank you. So Dr. Selom, could you please add on briefly for us?
Thank you very much for this opportunity to contribute. So in addition to what Prof. Penny has stated and also Mr. Osesapa from WHO, I think I want to also highlight that generally the program has some what we call programmatic costs, which generally because we work in the health service, we don't factor them as costs that come in. So for even the vaccine to move wherever, there has to be thinking that has to go in. You have to go for supervision. You have to go around and you have to go and do evaluations of your system to ensure that whatever training you've done, whatever coaching you have, whether it's working as it's supposed to be done. And since Gavi came in, Gavi has been funding this almost 100%. And so that's a major risk that as soon as we transition off, that funding is going to go away. I would also want to mention that at this point, we are currently implementing Gavi 6.0, and this has come with quite a very sharp drop in funding. So from next year going, for instance, our funding to be able to do programmatic things, take care of our coaching, etc., like Fred said, being in transition has already gone down. So it's very important that we look at immunization, not just as in the case of buying vaccines and just procuring them and letting them get to Ghana, but thinking of vaccines or vaccination as procuring the vaccines and getting them into the arms of the eligible child or adults who requires them. Thank you.
As Ghana have started transitioning in terms of financing, we also learned that a lot of countries globally have started already. So I want to ask, which international experiences in financing universal health coverage offer the most relevant lessons for Ghana? And then again, what contextual factors can Ghana consider before adapting such approaches? I'll start with Prof. Yate.
Thank you very much for the question. I'm Yete Nwame. We've had quite a detailed presentation from our presenters as to some of the, more like some of the innovative practices out there. One which has been amplified and over-amplified is the sin tax. There is also this one which we heard about the airline taxes also from Prof. Abire. There's been other discussions of the leaking, how do you call it, baskets, which we've been having due to all the other ways we handle the funds that we get. Recently, Prof. Amuna mentioned we were in Gambia as well. We arrived at the airport and you were supposed to produce $20. We said, Jack, what is this $20 for? It was explained to us later that that was a kind of airport tax which we were to pay, which is a form of innovation as well. Something can be gotten. Here we enter and we pay nothing, basically. When the COVID showed up, how much were we paying for the COVID screening and all that? If we had to compare it to $20, which would go into something. So yeah, there are all these innovative approaches which go to mobilizing revenue, go to how do you call it, programs are also implemented out there. So, but I want to divert a little bit from the issues of what? All these innovations. Whilst the discussions were going on, we talked about this, how do you call it, the mobile money tax which came up to us. There are other interventions that have been put forward in Ghana so far that, in a way, we've ended up just rubbishing them, if I'm to put it politely. A lot of this is going to the fact that we are not really, there can be very innovative stuff that we are doing, but if we've not built consensus across board, this guy sees it as up. All of a sudden, why are you taxing me on this? Another political figure takes it up and starts blackwashing that whole intervention. We don't end up sitting to actually discuss, see the merits of the various things we want to do out there. So for me, if you are to ask, we can talk all the innovations we want to talk here. If we don't think about how to contextualize those innovations, if we don't think of how to build consensus for all of us to agree on whatever we have to do, a lot of these innovations will come and go the same way as other good things have gone. So that's just what I'll leave for now whilst we move on. Thank you.
Dr. Ajua.
Thank you. So I think during the presentations, it was quite clear that syntaxes is one of the good ways to go when you want to mobilize resources. But as you clearly saw from the slides, when it comes to Philippines, when it comes to other countries, they actually used some of the revenue to support health programs. So for instance, in Mexico, where they increased the SSBs, much of the funding actually went into providing, so SSBs are sugar sweetened beverages, and they realized that they had a lot of obesity amongst school children. But once they did this, what they did was to provide water fountains in schools. So that is a health intervention. In Ghana, we also have syntaxes for tobacco, alcohol, and sugar sweetened beverages. And if you look at the excise tax amendment, which was made in 2023, we made a lot of gains. So if you do the analysis from customs, for instance, in 2021, the revenue from tobacco alone was about 72 million Ghana cedis. In 2024, post these excise law amendments, it shoot up to 420 million. Not just the 420 million, but it also showed that there's a reduction in the consumption of tobacco during that period. So just by using syntaxes, you are reducing consumption, you are reducing morbidity and mortality, at the same time you are increasing revenue. What is missing, that we are missing, is probably to say that, can we have some of that funding allocated to health? And that is where the CSOs and academia can come in. Because beyond this is just for tobacco. What happens if we analyze that for sugar sweetened beverages, and we do that for alcohol as well? We'll be looking at a great amount in revenue, which can support health. So syntaxis is already there in Ghana, but it's about where the funding is going. It's going into the consolidated fund, but we need to push and advocate for that to come to health.
Dr. Prof. Gilbert, yeah, do you want to say something?
Okay, let me just add something to that. So as I said in my presentation, I don't see any specific country as is a shining example that Ghana must copy from. Because Ghana itself is an innovator, and they are copying from us. And I think we are on the right path in terms of the discussions, and we have already identified what others are doing. But we now have to we have to see how do we adopt that. And when I listened to Prof. Novinho, his presentation, and the concluding part, and I really think that we need to think about this seriously. If we are talking about donor transition, and then we need to finance vaccine, there's a political opportunity now, which is a free primary health care. We need to tailor that discussion within the framework of the free primary care. And my friend who sat here said that politicians are not bound to have evidence before they make promises. They need to say, this is what I want. And when they come, we will have to guide them to design it. And I'm sure there are technical teams that are working on that. There are advocacy groups that are there. Let's frame the story. For example, we have what we should now be talking about. What do we go into the free primary health care? And immunization can be part of the package. Then the discussion will now be shifted to what new revenue sources can we generate in order to what? To finance this free primary health care. And that is why all these syntaxes and all that, we can explore that. But if we detect the discussions, at the end, if we go clearly off the free primary health care without immunization in that benefit package, we may regret later because whatever source we are thinking about may not be sustainable going forward. That's my contribution.
Thank you. Professor, we've seen the model that has been demonstrated, what Ghana is doing now concerning financing of healthcare and then towards primary healthcare as well. Would you agree to this, or you would propose something new? Or an amendment to it, what do you think Ghana should do about this model that we are using?
Thank you. I think the model as it stands now is perfect. It's good. What we need is a lot more commitment to realize the financing that we need for that agenda. At the National Vaccine Institute, we have had engagements with government to have a dedicated budget line for vaccines. In fact, a cabinet memo was submitted with regards to that, so that from the National Health Insurance Scheme, there's a dedicated line item for vaccine procurement and all the related matters that were mentioned earlier on. If it is also covered in the primary healthcare agenda, that would also help. So that would have plugged all the necessary holes in attempting to solve the financing issues when it comes to vaccines. Thank you.
So the term here is earmarking, right? Do we all as panelists agree that probably we should push that agenda, earmarking towards financing immunization, primary health care?
Absolutely.
That is something that the country should be looking at.
We should. And just like Ajo said, there's a lot of revenue that comes into the bigger pool, but we have to be deliberate about earmarking that to healthcare and more importantly to vaccines. If we are going to do that, it will need a lot of political commitment. And so if it happens within a particular political season and it changes in the next, then it becomes problematic. But if all actors can come together and agree that that is what we need and it is done, I'm very sure that we would be able to solve the problem. Thank you.
Dr. Selom, do you also agree to this? Okay, Mr. Fred, say. She's online. Yes. She's muted. Could you unmute yourself, please?
Yes. Sorry. I just missed that, please.
Yes, we were talking about earmarking towards financing immunization, primary health care, and we want to hear what you think about that. Is it the way to go? Should we really advocate and ensure that this is done for Ghana?
I think that's one thing that we should look at, and it's something that Gavi is even proposing we do, because our neighbors next door, Cote d'Ivoire, they have it in their, it's clearly shown in their budget that there's something for immunization. And also some countries have also looked at doing some kind of earmarked funds. It could be in the form of just like fund, maybe it's a health fund, but they know this is meant for immunization, or it could also be in the form of like a little trust fund that is specifically for immunization. But it's always good to have some fund that you can point to as funding that you want to be able to use to take care of these services going forward. Yeah.
Okay, so since Ghana have already earmarked, how can Ghana expand the physical space for health and strengthening strategic purchasing mechanism whilst it still maintains its financial protection for its vulnerable population? I'll start with Prof. Abiru.
Yeah. So you mentioned two things: how to expand physical space and how to strengthen what purchasing. And we are discussing about strengthening physical space, and that is why we spoke about bringing in new taxes, and even the earmarking alone is also something that can make money, not increasing the total amount of money available, but make more money available for health. Then we can explore all the other options of sin taxes and all that. Something came to mind in terms of vaccine financing. You know, the social impact bonds. So if you have a private provider who can actually provide and produce evidence, then we pay the person. But at least we still need other money to not pay that provider. And that is very important. Then in terms of purchasing, I actually, like I said in my presentation, Ghana is doing very well, but what is just lacking is the value for money bit. How do we ensure that we pay based on what output? For instance, vaccination. Do we just give the money out, or do we need to get evidence that people are really receiving the vaccine at the right time, at the right place, and the right quantities? And that can only be done if we bring in payment models such as what? at least capitation, if not. But if we can get performance-based financing, having clear indicators, then we think about that. So I think we really need Ghana. What I see as a gap in terms of the Ghanaian system is how to make purchasing value-based. And like I said, we started it in the Ashanti region. And when you look at the data, it's not like the providers were not very happy about it, but it is the political dynamics. So starting it again or thinking about that, there's a lot of political dynamics surrounding reforms around that. And we need to start from behind. And I think civil society organizations, academia can take up this. Drum home the message again, that it will get into policy attention. Then it's a message from academia. Then we'll see how we can get bipartisan support for it. That is what I will add. Thank you.
Dr. Chumbarima.
So beyond the health taxes, which we've spoken about, there are other areas, like we've spoken about the mining companies, for instance, the extractive levies, if you can consider a small percentage. I do know that when we were putting together the bill for the Ghana Medical Trust Fund, it came up. But some way, somehow, that was dropped. It's something that we can actually consider. The other thing is road levies as well, because RTAs are all coming as a very important thing to consider as a causation of health morbidity and mortality. So then when we are making these investment case agreements, we need to share with them that probably the road levies, we should probably get something small for health as well. But beyond getting more money for health, there's a new paradigm shift really, which looks at more health for the money that we have. Because that is also another way of creating more space, fiscal space. It means that when it comes to the inefficiencies, we must start looking at those so that we can actually disallocate from certain areas and think of pushing into areas which are more efficient. And that is very critical now, especially looking at how our donor support is dwindling. We need to go back to the drawing table, look at the places where we've been inefficient. As Dr. Jokoto clearly showed us, just by using AI to look at some of their claim systems, they are able to share that probably they are paying about 10 to 15% to providers when they don't need to. That 10-15% could go into something else, could go into vaccine procurement. That is money which is going down the drain just due to inefficiencies. There's another thing coming up which I want to share as well. It's called Health for Debt Swap, where we are looking at donors. You know, we owe some countries, we owe some donors. We are saying that if we can commit some of these funding, these monies that we owe you, to some health outcomes, would you consider reducing the debts and saying that instead of you paying me 100 billion, use that 100 billion to do this, that in the health space? These are things that we are also pushing in the WHO front to see how donors can actually look at this. This is very good for Ghana, for instance, because it means that we will not be thinking of putting foreign currency together to go and pay our debts, but rather that money will be local money. At the same time, we are using that local money to support our health outcomes, and we are gaining more. But when it comes to strategic purchasing, if you look at the benefit package of NHIA, very generous, covering about 95% of the health burden of the country. Over the years, it has stayed as such. If you look at the benefit package of the Ghana Medical Trust Fund, it took away just a few of the cancers which were already covered by NHIA. It means that probably we need to look at all these interventions critically, whether we can actually do a cost-benefit analysis for all these interventions that we are actually supporting. That is why the HTA Secretariat is critical in this case, because over the years, we have continued to actually purchase these same baskets over all these years. We are finding it difficult to disallocate or actually move funds around a bit and say that probably if you look at this intervention, it is no more cost-wise, it's no more beneficial to the country. Let's disinvest from this and do this, which has been shown to be much more costly. That is the way of going when it comes to strategic purchasing. Over the years, Ministry of Health has tried with a framework contracting, where they were looking at pooled procurement. I don't know what the state is now. There were certain commodities or drugs on the National Health Insurance Medicines list, which could be procured in that pool manner. What happened was that it means that we reduced the cost a bit. I think we need to go back to that drawing table and see how we can perfect that system. I know there were challenges with that when it came to supply sometimes, but we need to go back and see how we can actually work on that and make it better.
Thank you. Prof, can you add something?
Thank you very much. I think we've discussed a lot about more like revenue mobilization and all that, but I still want to bring up this one about the, how do you call it, the salary-based, and also, I don't think we've talked much about the informal sector. Whether we like it or not, Ghana's informal sector is quite huge, and there's so much going on there. How do we mop up those excesses from the informal sector as well? The salary-based, that's one as well we mentioned. I think it's a good thing to go. Most faculty here are not on that. We those who are not contributing to SNIT. If we are to start that, I hope we will not go on a looter that. Okay. And that's where I still will bring myself back to that level of creating awareness among ourselves, getting to know that all these things are not just to punish anyone, but it's leading to our collective benefit. We talk about the syntaxes, for example, making it sound as if it's something quite unusual. Whether you like it or not, you are taking a beverage there. You will also be contributing to that syntax. Someone is smoking cigarettes, he or she is contributing to that syntax. So if we look at it from another angle, in our whole collective, we will somehow all be contributing one way or the other. These vaccines we keep talking about as what? Once they are administered and other things, they end up saving us costs because people might remain healthier. They might not be curing some of these conditions in the long term. But let's also see it as the other way of we all benefiting that we are healthy. Okay, once you grow healthy, you are also there to produce more, to actually enhance the economy of the country, be more relevant to your people who are around you. So most of these things, I think the way we market them as well, to kind of like enhance societal awareness and that level of consciousness to make a collective contribution to our health for me is quite key. Okay, so that's one angle I'll move in from. When it comes to procurement of the vaccines and all that, a lot of stuff have been mentioned around here. But I'm trying to think back to our, we don't like talking about this, but those are the realities we face. How is our procurement system, as we call it? Okay, we all know, we discussed with Prof. Abir, the team from UDS. We are hiding and pretending that our procurement systems are top-notch. The very things that the procurement systems were here to do for us, are they serving that purpose? Something that I know is 1 CD. If I go through procurement, how does it end up being? So at this point in time, as a people, we've got to stand up and say, the institutions we have, the structures we have in place, are they fit for purpose? Are they even serving the things for which we want them to serve? I'll go on to another one. Maybe I'm digressing a little bit, but forgive me for that. Yeah, we are talking about let's show up finances to procure vaccines, for example. We are not producing the vaccines as it stands now. We are also not getting the funds. How long can we continue with this? We borrow somebody's money to buy someone's food. How long will it sustain us? We are talking about sustainability. So though I've heard about the vaccine institutes programs, they are very laudable. But this whole argument that we have to be thinking about what? The production, once we produce, you might have to think about how other people will procure them from us. We've got to at least start doing something for ourselves. If we are taking what we are producing and we are happy with it, that would be the best market for the outsiders also to see that you guys are doing something good. So I will still appeal that we shouldn't just be saying that we are going to be producing at those scales to think of exports and other things without we actually creating that market from within. And let's not forget, our taste as a people has also been, in a way, foreignized. We might bring in vaccines now and say, this one is from Ernest. Let's leave it there. Let's go for the one that's coming from the foreign producer. So those are just things I want to throw in there. As I said, I'll digress a bit, but
Please,
thank you very
Professor
much.
wants to add on a bit to what you are saying.
The digression falls. So we at the National Vaccine Institute, we just completed a survey where we ask the Ghanaian population whether they would procure locally manufactured vaccines. And over 75% said yes, they would. They would take it up. And so it's encouraging to know that people are ready to use made in Ghana vaccines. One of the things that we're doing now is to go public, have a number of campaigns to promote the vaccines that we are about producing. Hopefully by first quarter next year, tetanus diphtheria vaccine should be released by first quarter next year. Now, what we have done is to also engage African CDC and then AVMA, AMA, to discuss the concept of pool procurement. We've had a number of meetings where we are agreeing on the procurement mechanisms, and also we've been able to get the attention of government to commit to advance purchase of the vaccines that we'll produce. Now, what is happening now is that we're getting a lot of attention from the region, and so we've started negotiations and discussions with other African countries to procure from us. What we are doing with the manufacturer now is to make sure that whatever goes into production will not be too expensive for uptake, so that the cost variance for what we produce locally compared to what we probably may buy through UNICEF will not be that much. So it will be easier for government to buy, and it will be easier for other African countries to also buy. We currently are finalizing our market strategy for the locally manufactured vaccines. There's also a lot of work being done on demand and then forecasting for the vaccines. We're working with Selom and her team as well to prioritize what vaccines we should be researching into, what vaccines we should be producing locally. And so on the landscape, I can say that we're positioning ourselves very well as a country. What we need is a lot of support, especially from all of us in this room, both private and public, to increase the funding that goes into the manufacturing, the procurement, the cold chain management systems, the data systems, and all of that. And I believe that come next year, Ghana would be on the map. In fact, our target is to produce and also sell to Europe. Thank you.
That's really, really good news for us as we leave.
Thank you so much. It's so exciting to hear that very soon we'll be producing our own vaccines. But I just also want to send a word of caution that we should be careful not to make it in a way that will not serve the purpose. Because you hinted that you are trying to use ingredients that will make it a little bit cheaper compared to that we export. And I just want to caution that we should be careful, because we have the future of our country in our hands, so that we don't produce substandard vaccines that will not serve the purpose of vaccination. Yes, my name is Abdullah Abubakar. Yes, from UDS. Yeah.
Okay, so just to clarify, we are not producing substandard vaccines. If you look at the manufacturing landscape, a lot goes into the GMP compliance, WHO pre-qualification, and all of that. What we are doing is to leverage on local expertise in the production process. So for instance, if it would cost, let's say, about $20,000 to bring someone from Indonesia, Japan, or Germany, Do we have that expertise in Ghana? If yes, can we use that person in the process? So those are some of the things that will bring down the cost. So we're looking at human resource, we're looking at technology and all of that locally in the manufacturing process. But obviously quality is not an option, because before the FDA would even have to approve the vaccine, it has to go through a number of rigorous and very detailed assessments before it is released. So as for quality, I can assure you that we're not compromising on that. In fact, the Ghana FDA is 1 out of 9 that has reached maturity level 3, and their target is to reach level 4 in WHO PQ. So they are very much aware of the requirements to produce a vaccine, and for quality, it is not something that we want to joke with. Thank you.
We are grateful to the NVI for the work that they are doing, and we believe that it's going to be very helpful to the country. So, Prof. Feni, if you are there, my last question goes to you. Are there any lessons that Ghana can learn from countries that have already transitioned off Gavi support? Are there any lessons at all that Ghana can learn? Thank you.
Thank you very much for this question. I have struggled to find, especially on the continent, any good lessons, because we've had countries who transitioned, but unfortunately came back for Gavi support because the structures were not really put in place. And that was one of our big fears when we started out with this assignment, that we shouldn't come to the place where we actually transition and come back. And so I can't point to a very good example, I'm afraid. But again, maybe I missed something. I haven't done an extensive review on this, so I may have missed a country that did it perfectly. But I know Kenya, I'm not sure about Angola, but please, Dr. Kusasi, you're here. Do you know any country that has transitioned and successfully stayed in that space, please? Thanks, over.
Okay,
Yes,
so I'll come in when you're talking. I was just smiling because I also went scouting myself, and Angola is back in Gavi. In fact, Kenya has left accelerated transition and is now back in preparatory transition stage. So for now, I have not been able to identify any particular country within our context that has done that. There are countries outside our context that have transitioned. Countries like Indonesia, countries like, well, initially Bangladesh. I think Bangladesh should probably be on its way back now. But the ways they're able to go around it are multifactorial. So it's not just financing issues. You realize that there are other health system things that come in, and primarily primary healthcare and health financing and being able to finance the healthcare system generally are things that are good markers of being able to transition and stay transitioned. So maybe in our context, no, but we see countries around making plans to get out of Gavi. So for instance, the Cote d'Ivoire example I mentioned earlier, for instance, having the vaccine already, having a line in your budget for immunization means that when the year begins, Ministry of Finance knows I have to put money here for vaccination. Then the Ministry of Health is able to draw down that budget and also use it for the funding instead of our current system where we are kind of buried into the goods and services. So I think that regarding our context or in Africa, currently there is nobody. And maybe WHO can also tell us if they've seen anybody. I have done a little bit of search around. I couldn't.
WHO is here.
Thank you.
Yes, thank you very much. Yeah, so
and this would be your last remarks today.
Yeah, so Kenya attempted, Angola also did, but unfortunately they could not transition from Gavi support. It wasn't entirely on their inability to make funding available, but you know, for Gavi, there are eligibility thresholds, depending on where your country sits in terms of your GNI per capita. So if your GNI per capita is below the lower income threshold, that's where you sit on the Gavi grade. If you're above it, that's where you sit. But if you go beyond $2,300, then you move into accelerated transition. And that's where Ghana finds ourselves. But then there are very good examples globally that we can learn from. But one theme that runs through all countries that have successfully transitioned from Gavi support is commitment. Commitment from the government, commitment from our politicians from all divides, commitment from civil society, and from all of us. Because once there is commitment, once there is a will, there will certainly be a way. The other one is that they all have immunization budget as a line item in their national budget. So if you look at countries like Bolivia, Azerbaijan, Cuba, all of them have immunization well or clearly captured in their national budget, because immunization is one single intervention that all of us go through. Yeah, for other interventions, unless you have the disease or whatever, you are unlikely to benefit from it. But for immunization, in fact, for many of us, we are alive because of the power of vaccines. Yeah, so clearly they've earmarked, or there is a line item for the purchasing, not just for the purchasing, but also for the delivery of vaccines. Beyond that, immunization has been integrated as a key component of their primary healthcare system. And for most of these countries, immunization has been the bedrock of their primary healthcare delivery. And for Ghana, I think that the situation is the same. In fact, most of the interventions, especially public health interventions, run at the back of the immunization program. So if you're able to strengthen the immunization program, we are, by extension, strengthening the other interventions we have in the country. But one single most important thing probably I should be talking about is the need to have legal and regulatory framework around these. Because whatever we discuss, beyond this room, there could be a communique, a white paper to cabinet. Some of these will turn into policies implemented by government. But then they are the mercy of our political leaders. But once there are legal and regulatory frameworks to kind of support some of these policies to withstand political changes, then we are very sure we are on the right track towards sustaining our immunization program. Thank you very much.
Prof. Yeti, your last words.
Thank you very much. There has been, I think, the evidence about, how do you call it, pooling resources, we cannot dispute that. Okay, and also, so far what we've heard, lessons from, I think we might have to go back a bit more, find out lessons from those who haven't been able to maintain the, maintain the transition, or once they've transitioned, being in a transition mode. I think they are the ones we've got to go back and learn from a bit, because as for those who are still striving, we might take their stuff and it will not be what it is. I believe us also producing ourselves and generating our own resources to actually maintain that production and also maintain the use is a key thing for us. So I don't think I'll belabor the point. I'll just say thank you for this, and I hope, yeah. Okay.
Yeah, so on the issue of vaccine production, I'm happy Prof is here. Yeah, I know MVI is doing a lot, coordinating yes within that space. But countries that actually succeeded in leveraging the support of their vaccine institute to support the immunization program, it wasn't just about producing vaccines on their immunization program per se. You can be producing other vaccines, but then you make it a point that for every dose of a vaccine that leaves the country, a certain proportion is set aside towards our immunization program. So we can be producing anti-snake, anti-rabies, anti-whatever, get people to buy within Ghana, outside Ghana, but then we make that commitment that every dose of vaccine procured from a manufacturing plant in Ghana will go into the basket for financing immunization. And I think Prof agrees perfectly with me. Thank you very much.
I wholeheartedly agree. And also to mention that we are at the final stages of releasing the anti-snake venom. Yes, we are at the final stages of releasing the anti-snake venom. So hopefully a few documentations here and there, and then before the year ends, that should also be released.
Prof, your final words, please.
Oh, just to say that we are on the move as a country. I like the conversations, and just as I said a bit earlier, we need to set the agenda on healthcare financing properly. It shouldn't end here. We should make a conscious effort to continue the conversation, sustain the pressure until we see the line item in our budget clearly stated. Thank you very much.
Prof. Abiu.
Yeah, just in the same way, I think Ghana, we are doing very well, and a number of countries are actually coming to learn from us. So let's keep up to that. Let's be open to innovations, and then see how far God will take us. So those are the last words that I will give. Thank you.
Before you do that, please hear from him, then we would end with Doc.
Thank you so much. I just want to add that in terms of political commitment, I think we have a very good starting point, because Parliament of Ghana has already constituted a parliamentary caucus on this transition process. And so even after this discussion or this forum, the white paper that may come out could also be sent to the parliamentary caucus on the transition process. I think that will help a lot.
Great, Doc. So your final words too.
I would talk about the importance of what we are doing here today, for instance, placing academia, CSOs in that conversation. I think it's something that we must encourage, and it's something that everybody must look forward to, because you have a great opportunity of even suggesting other ways, other innovative ways in which we can increase financing. And I will say that there's something that our regional director, Professor Janibi, says. He says, sometimes we are being asked to think outside the box. Maybe now, and everybody says sin taxes, everybody says extractive, everybody says road taxes. Maybe academia should rather be telling us what we should do. And in so doing, they shouldn't look at a box, because there is no box. So we are leaving this with you. That when we leave here, we want academia to be able to suggest to us what other innovative health financing mechanisms can Ghana actually use to support immunizations, to support vaccines, and to support health. Thank you.
My last one I wanted to add. Actually, I asked for the mic and I heard you now talking. Don't let it sound like I'm responding to you, because I was about to say that academia has been there, produced so much, academia and research. There are several files decorating the shelves, which are not really going into practice. So lots of times, a lot of the academic questions might be set out of a level of unawareness of the context. So please, you those in industry, you those wherever you may be, you will be working and find out some problems. Just communicate with your academic friends. They would also now come with their thinking cap on, and we'll support each other to actually attain. Okay? At times, you might not just be sitting in our room. I remember when we were in Kintampo, we had an issue once. We were thinking about some adolescent health issues. We had brainstormed for 2 weeks as a group, and someone just said, no, there's that midwife in town who has been dealing with these issues. Why not talk to her? A less than 2-hour conversation, everything was clear. So please, you those implementing, don't shy away from contacting academia. Don't shy away from talking to researchers. Don't struggle with your problems in your coop. Come out, let's talk, and I think we'll do far better than we are doing. Thank you very much.
Thank you. Let's clap for them one more time. Please, my panelists, sit down. You are not permitted to go. Thank you. So thank you all for taking the time and speaking to us. So one thing, transitioning from research to development is one of the reasons why MVI poached Professor from UHAS to come and sit with them. So we are hoping to see something good coming out from the MVI with his leadership. So we are giving you 5 minutes to ask questions. So 5 minutes is fine, right? All right, yeah, good. So the other microphone, someone can help me. Don't worry. So that 1. All right, 2. So if you want to ask a question, you can raise your hand. We'll take note of you. Comments and questions, yes. All right, so you can go ahead, Doc.
Yeah, thank you very much. I think we thank all the panelists and organizers for this important thing. Public health is what we as a society do to assure conditions of everybody healthy. Like as said by National Association of Medicines, my issue is, 1, we have a timeline for elimination of diseases in this country. Now that we are transitioning from Gavi, we were setting those timelines because we were getting support somewhere in terms of the vaccine. And we are going to do some transition from there now. Is it going to affect our timelines for the elimination and also those diseases that we have almost eliminated? Are we going to wait for them for re-emerging? And what type of pressure are we going to put in the system to know that it's not routine or it's not as usual? It's because of this timeline of eradication or elimination, they should support the vaccine issues in the country. The other one is, the other presentation when they were doing, they look at people, they were taxing alcohol, but they were not taxing herbalists, the herbal products. In fact, those practices end up in our facilities and then put huge bills on the facilities due to the bed occupancy, the conditions that they bring. How are we going to capture those people? Because the activities cost most of the things in our hospital, including those in churches selling holy water, assuring people the conditions that the holy water cannot do. What can we do to bring those people on board? And then my good prof who said that we should link health insurance to school admission and those things. I think we should get to the churches, or to church membership should be linked to health insurance. Then the coverage can be wider.
All right.
These are some of them. Thank you very much for this.
Thank you. So, Dr. Selom, the API coordinator is online. I think he can respond to the first question. All right, so all of them together. All right, so.
Okay, so I want to just state that not all the vaccines or not all the conditions that we are currently giving vaccines for are marked for elimination, eradication, etc. That is, I think, the baseline for it. And what we are currently doing, even where we are not going to get, or we are going to get reduced funding, we are making sure or trying to ensure that we have enough, we are able to maintain those kind of vaccines for the conditions that we are not in those elimination or eradication phases for. So I don't think that, or maybe when I say, I think that the reason we are doing this exercise is not to get to the point where we are going to have these conditions as something that is going to re-emerge. Prof. Feni highlighted the risk of outbreaks and things already during her presentation. So I think that it's important that as we know that some of these things can come back in a bigger form. So for instance, Nigeria has been going through a diphtheria outbreak for the past, I don't know how many years now. And luckily for us in Ghana, we haven't gotten to the point of getting diphtheria outbreaks. We're not getting the outbreaks of polio and the rest other countries are getting. But it's because we're able to have vaccines available for our people. So it's important that as much as we know we are going to transition, as much as we know that there's going to be reduced funding going forward, we also have to plan to make sure the country is able to find money from somewhere. That's the basic of it. Find money from somewhere to procure the vaccines and get the vaccines from the cold room in Accra into the hands of a child sitting in Rara. Thank you.
Thank you. So I think we'll add up the rest of the questions then and comments as well. So, Doc, over to you.
Thank you. Good afternoon. Just a contribution. If we listen to the presentations, especially the one from the Health Insurance Authority, we are sure that we want to increase the preventive aspect of health so that we have a healthy population and we do not need much to spend on curative measures. And this is very important. So I've been thinking about the PHC concept or the free PHC concept. The goal is to ensure that people are healthy. But I ask ourselves, especially those of us in this environment, how do we benefit from this? Because some of the time, we do not even have the time to go for preventive checks. And so instead of thinking about, okay, we are riding on the CHIPS compounds, the polyclinics to continue their work, we should also begin to think about bringing some of these services to the doorsteps. Because if I'm driving and I know when I park, I see somebody who can check my BP. Today I see him, I may ignore him, but tomorrow something will say pass by. We go for events like this and people are sitting outside. I see it as a cheap opportunity to have access to some of these things. And it's really going to help us. If we leave it in the mainstream, that okay, it is a regular system, we have the people at the polyclinic, the people at the CHIPS compound, they should carry on with their work. They will continue, but we may not see the benefits of this. But when we start bringing it to the doorstep, a university like UHAS should have a system where we can buy BP apparatuses. School can have these things. I walk up to the dean's office, I can check my BP if it's the automated one. That is just behavioral, so that we have things that we can actually, we know of, we are not able to do, but this time around they are available and we can easily get them. Thank you very much.
All right, thank you. I could see it. Okay, Prof. Kugbe has a comment.
Thank you very much. The whole day was spent talking about money. But we know that getting money from people also comes with the issue of trust. I'm talking as a psychologist and the behavioral sciences. Now, when e-levy came, e-levy was used as an example. When e-levy came, a professor in my school did a study on willingness of Ghanaians to pay and how much they were willing to pay in terms of percentage. In fact, people were willing to, over 80% of the population sampled were willing to pay 0.05%. Now that means that if we had done engagement and people have trust in the system, knowing that the monies that they will be contributing or that will be taken from them will be used or will be beneficial to everybody. Because if about 20% goes into people's pockets, people will not be willing to pay. Because if I know as a lecturer, if you take my 20% to put to a health fund, if I'm sick or somebody is sick, I can access healthcare, quality healthcare. I will feel free to pay for that. I was asking my students whether they think the premium we even pay for national health insurance is realistic. A lot of them said no. Because I said, what can 20 cities or 27 cities buy? We need to, I think we need to decouple party politics from healthcare issues. One of the things that we shy away, if we really want to achieve the primary healthcare that we want to do, we should do things, even though health is politics, but within the Ghanaian system, party politics should be away from it, such that we can do things where we can block the loopholes and then create a trust in the system so that when we ask people, Prof, if they put tax on petroleum products, like the increase for, I will tell you that people will start buying a lot of Chinese vehicles, the electric vehicle, because when mobile money came, people started doing some strategies to evade the e-levy.
The charges.
So because there's that lack of trust, so people are not willing to commit their money into it. So I think it behoves on all of us to build that trust so that we can have trust in our politicians, public institutions, so we all, achieve what we want to achieve for our country. Thank you.
All right, thank you so much, Prof. So, another hand, Samuel, Josh, okay. Okay.
What I was going to talk about, I think it's already been discussed, because I was worried about how much of our projections would be sustainable into the future. For example, if you talk about sin tax, like he said, when you tell people that they are sinning and you are taxing them, they repent. So then the challenge is that you would not have the projected income that you are thinking about on a sustainable basis. When we were younger, I mean, Great Embassy Double Do, there was a Miss Ghana contest. They were all being sponsored by tobacco companies. The British American tobacco has collapsed in Ghana because of the taxes and other things that were introduced. So people have the tendency to change their behavior. But the bigger question is that, again, we are looking at some of these transitions as only a health transition. But it is soon going to catch other areas of our national life, that other subsidies that we've been getting would be truncated. How much does the National Development Planning Commission think about projecting what Ghana should be in the next 10 years, in the next 20 years? What is the Ghana that we want in the next 10 years? And if we look at that Ghana, there would be the health component of Ghana, there will be the social component of Ghana, there will be the infrastructure of Ghana, but we have a holistic planning for our country. That is a challenge that we are not tackling holistically. And so, yes, I see us talking about these syntaxes here now, but in 4 years' time, they may not be relevant. In 2 years' time, they will not generate that kind of income flows. And like he said, we'll be buying EV vehicles, so nobody will be buying fuel that much. Diesel is being phased out in Europe. And for that matter, now you see diesel cars are cheaper in Ghana. But they are shipping them to us. When we also start changing and we realize that, okay, we have a choice not to buy diesel cars, what happens? So you see prices of diesel are higher than prices of super or the normal fuel. But after some time, it will become irrelevant. And so I think we need to get into this state of planning on a sustainable basis and looking into the future and projecting what we want our Ghana to be in the future. Thank you.
All right, thank you. So I think that's okay.
Please, thank you for this important discussion. My name is Blessing from the School of Public Health. So please, my concern is, what measures are being considered to ensure that anti-snake venom remains affordable and accessible to all, especially for people in underserved and less privileged communities? Thank you.
Thank you, Blaise.
Thank you for the opportunity. My name is Lucy Jani Binka. I work at the Whole Teaching Hospital. So I would like to know, in the presentation by the Deputy CEO of the NHIA, he mentioned for the free primary health care, they were going to pay ahead of time so that the promotive and preventive services could be carried out. My question is, how was the amount determined? Because for the curative services, we know there are tariffs. So that's why when we provide clinical services, we are able to present claims. So for these promotive services and preventive ones, how did we arrive at those amounts? And then are they going to be reviewed upward in the near future? Thank you.
All right, thank you. So the question on taxation of herbal products that contributes to I think I'll call upon Professor Gilbert, since he has worked around an area on taxations and funding options, your views on that question for us. And questions on the free primary health care, I think Professor Anori has a good background now. You have to respond to that for us. So I think there's, Dr. Aziato was talking about benefits, bringing these services to the doorsteps of faculties as well. So you can approach that for us if that's possible.
All right. So just brief. So he is coming from the perspective of syntaxes, isn't it? Yeah. As regards, for example, so herbal products and all will cause harm, so we need to tax them. But of course, whether do we have consensus in Ghana that that's actually a sin? You know, there are others who also argue that no, please, let's go for herbal treatment and whatever and all that. So that's a controversial issue. It is supposed to be established that it's a sin. It's something that we are all against, and how do we do it? So there's no any clear stance on that. I don't know if others have comments to add. So that's just, I think it's an opinion. And he even mentioned churches and all that. So I think the idea is that let's expand the network and cover as many as what possible, but not just the herbal that he's more particular about.
All right.
So when it comes to syntaxes, other countries, apart from what we had mentioned, the alcohol, tobacco, other countries, for instance, tax food dyes, for instance, because they can clearly show what happens. When it comes to herbal preparations, there's a lot of regulation going on with herbal preparation. So we should be careful to make it seem like it is not a healthy option. When you have regulation, herbal products, if it's well regulated, may be actually healthy. So we should be careful about that. But beyond that, I would like to also address some of the issues with the free primary healthcare. Like what he said about the fact that we should probably not consider stationary structures. If you look at the free primary healthcare concept as it is now, we are actually running away from that. So the concept actually talks about how we operationalize chips as we wanted it to be. It's not supposed to be a stationary thing. So midwives or community health nurses are to go into the communities, into your homes, and come to you and come and do these assessments. So if you've been watching most of the launch videos, you realize that it comes with a bag, a red bag, which has a lot of things in there. The sphig, the glucometer, all that in the bag. So that when you actually enter a home, somebody's house, you are able to talk to them about the health promotive aspects and go ahead and actually do these things. So yeah, so health is coming to your doorsteps now. But beyond even your homes, now there are talks of health kiosks, where for instance at lorry stations, lorry parks, market areas, you are going to have these health posts there as well, so that our mothers there do not necessarily have to find a CHIPS compound or a polyclinic to be able to access this. And I think that if you're able to implement this, we'll be bringing it much more closer to the doorsteps of Ghanaians. To answer what she asked about costing, how this was determined. So when it comes to the prospective payments for free primary health care, it's population-based. And to get to that population base, you need to know how much you are going to pay per person in the country, which is called the per capita. For you to be able to have done that, you needed to have costed the benefit package of the free primary health care. You have to consider everything that you want to do. Who is delivering it? So if a community health nurse is going into the community, what is the cost? How many minutes of the person's day is going to go into that intervention? And you need to cost it based on, for instance, the person's salary. The services, as we said, if we were adding vaccines to it, vaccine will be there. So you cost all these interventions. And then you consider the population, and then you come up with the per capita. So what will happen is that if, for instance, the population of Ho is 100,000, you are looking at the people in the 100,000. So times the per capita, which has been calculated, is what will be given to Ho. But what is also good about this new things, reforms going with the NHIA, is the fact that beyond giving you 100,000 today, when next they are going to pay you, so what the plan is to pay you every quarter. When next they are going to pay you for that, they'll look at the indicators. What did you actually achieve with the 100,000 that I gave you?
So there will be adjusters. So you will not be there expecting 100,000 every quarter, because they will be on the ground monitoring to make sure that there's value for money. When you said you were doing all these promotive services, did you actually go into the community to have it done? And there'll be checks and balances. And then there's equity adjusters. So for instance, I'm paying somebody in Ho 100,000. Maybe for some of the hard to reach areas beyond Dambai and all that, I can't pay them just because of the population, because probably people have to travel for a longer period to get access to some of these facilities. So sometimes all these adjusters will be made. So it is the way to go. It is the best way when it comes to strategic purchasing, to look at population based. And I was happy when you were giving the presentation that when you are actually thinking of strategic purchasing for primary healthcare, you don't consider only one mode. So you realize that NHIA is now looking at population-based payment for the promotive and preventive services. But when it comes to the curative, they are doing GDRGs and fee for service.
So, I think, so anti-snake affordability issue, I would want to draw our attention, Professor, and you resolve that for us.
The cost?
Yes.
Oh,
very affordable for in undeserved
It is very affordable.
The question is how affordable?
It is very affordable. You see, one of the things that goes into production is also to be mindful of the market. So, like I gave the example about the vaccines. It's the same manufacturer that is produced the anti-snake venom. So those considerations, for instance, we had CPMR. They assisted with a number of the processes. So this was more of like a state institution supporting the production. And so the cost of maybe the running cost for a number of things may not be as expensive as if we had sublet same to and all that. Now, a lot of considerations goes into the production and then the final cost just to stay competitive, because if we're going to produce it in Ghana, for instance, and we have to sell some to Nigeria and sell some to Ethiopia, Kenya, and the others, we cannot produce and sell to our people at 15 cities, let's say, and go and sell 10 cities or 5 cities elsewhere. No. So there's always that thinking that goes into competitive pricing, looking at what goes into the production. But this has been taken care of. So the snake, the anti-snake venom that you get would be almost the same price as the ones that we were getting previously. Thank you.
All right, thank you. So that brings us to the end.
Sorry, just to add a bit to what the EPR manager said about the elimination and eradication targets. Yes, yes, Ghana will be transitioning from Gavi support, but that does not mean the elimination and eradication targets are going to change. We are not dropping the ball. We want to make sure we achieve those elimination and eradication goals. What the transition means is that we are going to take ownership of our immunization program, try to be more impactful, more efficient in the way we do things. Someone said the honeymoon period where we had a lot of resources all over is over. Now the resources are going to be scarce, highly limited, so we need to work hand in hand with our researchers, hand in hand with academia, so every intervention we pursue or we implement is well informed and is sure to bring us more impact in terms of disease control. Thank you very much.
All right, thank you. So, Prof.
Thank you. I want to add a little bit to the syntax. You know, the syntax is a double-edged cutting sword. So if you implement the tax, and then those who are indulged in it stop along the way, you know, the conditions they cause exert huge burden on our health system. So if along the way they stop, it leads to increasing the physical space. what I mean is that it frees some money to be channeled to other healthcare services. And that is why the benefit of it is one end. Whether they continue or they stop, you still benefit from it. Because the money that was used to treat the conditions that are caused by the product will stop to happen. Yeah, it will continue. The benefit is everlasting. That is the point I just wanted to make.
All right, thank you. So let's put up for our panelists. You are duly discharged. So, whilst it takes we want to draw our chairperson's attention that we have come to the end of our today's activity and want to draw his attention to give us his closing remarks and a summary of the activities for the day. So let's give it up for Prof.
Right. Our day is coming to an end. Having sat in, I realized there is that we have it, and yeah, so it's very difficult for me to actually summarize in 10 minutes what we've done. I'm cautious of the fact that you are yet to have your lunch. But I think the day started very well and has continued. And my personal expectations have been met, and even more than that. I was asking myself whether I should go straight to the action points or try to highlight some of the things that were said. I'll try and see how it goes. The Vice Chancellor, in her remarks, admonished us to move from the talk to talk to action. And so I expect that this critical mass of experts and other contributors here will actually come together, and then we will put together some actionable things that we need to do. The other thing that I learned was the emphasis on the need for academia to work across various sectors in order to deliver results. And NHIA, Deputy CEO, emphasized the need for academia to work with them and their openness to actually work with academia. And indeed, we do know that those, some of those are already happening. And therefore, for us here, this is, if you like, a challenge to us that the NHIA is open for us to engage with them and to do business with them. I think when Hope for the Future was also addressing us, they talked about the role of academic institutions as sources of evidence generation and innovation, and to strengthen coordination for models of research mobilization. And of course, they also talked about the role of academia in advocacy, working with civil society. And so there is a lot in there for us to actually sort of ponder over and then to act upon. I was particularly interested in some of what Dr. Jokoto presented to us in terms of the ambition of the National Health Insurance Agency to move towards an 80% funding allocation towards real field work and only 20% for administration. While that's laudable, I think our concern has always been how this pie is divided. But we are also told that the focus of the NHIA at the moment has been more in response to the cash and carry system and has a curative dominance. And what they want to do is to shift more towards prevention and promotive healthcare finance. And I think that is something that those of us working in public health will be particularly pleased about. And again, we need to step into the gap and then respond to the challenge. I was interested in the list of preventive activities and the promotive activities he presented. And I realized that a lot of the things that were listed were around non-communicable diseases. That I found very, very interesting. Because here we are, we have the Medical Trust Fund that has been created specifically for NCDs. And we have a free primary healthcare system with an emphasis on NCDs as well in terms of the measurements, the monitorings, and so on. I found one sentence towards the end on screening. My question and the challenge to us is, what do we mean by screening? Is it opportunistic? Are we looking to advocate for a national screening program? Because if you have a national screening program, there are implications for it. If people go and they are screened, what next? And there was some small line on the referral pathway. And I think that is something that we here should be thinking about. How do we connect the dots and make sure that if there is screening and it is supported financially, it must end somewhere. You don't begin and then stop there. It is very, very important. It is pleasing to note the number of cancers that are now captured in the new system that he referred to. And so he emphasized the need to shift from predominantly curative expenditure towards more investments in prevention and promotion. And at that point, I ask, what is the role of the health promotion officer within the Ghana Health Service? I never heard anything about that human capital and the role that they can play. And it's something I'm throwing back at us to look at. There is so much, and I don't want to go through what everybody has said because, you know, time is fast spent. I think we are doing about 7% in terms of the Abuja Declaration. And as we're told by Professor Gavignon, 75% of AU countries are woefully behind. 75% of countries across Africa are not meeting what they sign up to. And so as we have heard today, we are very good at signing up to things. The implementation is important. And we've heard a lot about implementation science today. We've heard a lot about the need for us to work on that score. And in that sense, I believe that we all have a role to play, both as advocates and also as scientists and practitioners and academics. I will just go straight now to my questions. I wanted to talk a bit about some of the recommendations that were made by some of the speakers. Prof. Ayanuru was talking about the 3-tier approach in terms of how we actually utilize or how we approach funding for immunization and so on. During the panel discussions, I think some very interesting points came up. And but before that, I think I want to also acknowledge some of the points that the Global Health Advocacy Incubator said to us about the importance of academic partnerships and advocacy for primary health care, and moving beyond policy rhetoric to real translational research and actions. During the panel discussion, it was interesting to hear about the need for a national health insurance card to be needed compulsory for certain things as a way of forcing all of us to follow this. In South Korea, they say that 99% of their people are insured. No, they said 99.9%. They refuse to say 100%, but they say 99.9%. And when you ask them, they have a system where any child that is born automatically is put on the system. And it is payee. So the chairman of Samsung pays because they earn so much, and a laborer will pay according to their income. But when they have any problem, they are treated exactly the same. Right. We heard about the leakages in the system and the need for us to address them, plug in those gaps. And I was also quite intrigued by what we heard from Dr. Jokoto concerning how by plugging the gaps and addressing fraud and other inefficiencies, we can significantly add. In fact, he mentioned, I think it was 600 million cedis that we can gain from addressing those. And I think it's something for us to note. And right. And so I think I've talked about academia and what we can do. Prof. Abiro also gave us some highlights, very interesting comparisons in terms of how countries are doing by way of trying to address the funding gaps. Airline tickets, solidarity levy was one example, and I think Prof. Yeti alluded to the $40 that they took from us when we went to the Gambia last week. When you go in, you pay 20. When you come out, you pay 20. You can't escape. and the Gambians have a different line. Yeah, so, yeah. And I think a lot has been said about the e-levy and the missed opportunity. I am sad to say that in our communique and the subsequent media engagements we had at the last meeting that we co-hosted here at UHAS, we actually made a strong case that the e-levy should not be abolished, but it should be converted and become a source of funding. And I think we are all saying something along those lines in relation to the current situation with healthcare finance. And so I think at this point, I had some interesting points from the second panel, second and third panels as well. And I think I'll just summarize them. There's a need for commitment to produce vaccines, and the transition roadmap needs to capture the entire vaccine value chain. That's how I put it, including cold chain management, manufacture, and I think there was an emphasis on the human capital as well. We were told that the Ghana model is good. However, we need more than we need more commitment. And we told that Navi is engaging with government and it seeks to have a dedicated budget line for vaccines. And the word earmarking was very prominent. And we're told that it is not a separate budget, but making sure that there's visibility for those needs. And when I hear the thunder, I am very happy because it means my corn is going to grow healthily. And we are also told that we cannot escape the political dynamics. And so we have to learn to be good advocates and to lobby. And we are going to do that from here. You know, we are going to do that in a nice way. And let's also remember the point of the Vice Chancellor that we should begin to move away from the politics of difference. And we should put our nation first and think Ghana rather than, you know, and sometimes it's amazing when people want things to fail just so that, you know, it's a political point scoring. And I also heard about Health for Development swap. I think it came from WHO, and I found it very, very interesting, you know, where partners may be willing to actually forgive our debt, but then it will be converted and ring-fenced into some health or care financing model. And I think WHO has been leading in this regard, which is quite good to see. We heard about a Navi survey on procurement of locally manufactured vaccines, and over 75% of people are willing to purchase or to use vaccines that are produced locally. I'm sure this is very welcome, and we will again have to advocate on it because we need to promote all these things. Ghana is well positioned, but support is needed for increase in funding. We all have a role to play in this regard. And when they were asked about lessons from other countries, you know, I heard Professor Feni say that, well, you know, I can't really talk of any lessons. All they are doing is they are all going back. Everybody is going back to Gavi. That is a lesson. That is a lesson. So why not let's go and see what they have done in their transitions, where they are, and why they are going back. So that in our case, we are told there's a parliamentary select committee that has been put up. Great. But let us learn the lesson from their experiences so that when we move, we become like the Indonesians and the Singapores, and we don't go back. Because if the IMF story is anything to go by, we always say we won't go back, but we end up going back, which means we are not learning the lesson. So I think this is something we need to take seriously. So in terms of actions, ladies and gentlemen, what are the lessons from today? Each one of us should reflect on that. What are the main highlights for you, for me? What actions are needed? What actions do we need to take? And where do we go from here? Well, I have some ideas. Number one is that we need to put out a communique so people will know that this meeting has held, and the deliberations, the key things, and the outcomes or the outputs from this. What it means is that we are going to lean on some of you to be part of a small committee to put together the communique, including those, some of you who sat here and some who were there asking questions. So your work is not done yet. All right. And please, I hope that we'll all actively participate in this. Number two is that we have to develop policy briefs from this meeting. And again, we're going to put together, I'm sure we can get about 4 or 5 policy briefs because there's so much and so much richness. And we've got some data to help us with that. And then the next thing we'll do is that earlier we were talking about during the break. We're talking about, okay, so what do we do? How do we, lobby? We have people here from government. We have, unfortunately, we don't have any MP here today. But we know them. They are on the health committee and others, and I'm sure we need to take this forward. So policy briefs, the communique, and then we should also serve as an advocacy lobby. We should come together. In that sense, I want to propose that we actually create a community of practice that we all belong to. All of us will be on it online, and then we can start from there. We have somebody has already said that this should not end here. We should continue the dialogue. The best way is to have a community of practice, and then we use that as a platform. And partnerships for research, both amongst ourselves as academics and also in collaboration with our other partners who are here. This is also very important because from today, you can see there's still a lot of room for further research to be done. And we should drive towards an annual forum as a policy dialogue platform on our key health issues in this country. And in this regard, I would like to challenge and appeal to our partners from Guy and from Hope that we need to put together an MOU and then we'll operationalize it. The Vice-Chancellor alluded to that in her remarks. So the university is committed. The University of Health and Allied Sciences is your friend. When we are here and we are ready, we are open for business, we are open for dialogue, cooperation, and serious partnership. And so I think that these are the points that I wanted to make. And permit me now to, on behalf of the Vice-Chancellor, Professor Lydia Aziato, who was here with us in the morning but had to step out for other commitments. I'd like to thank all of you for making it here to home, the oxygen city, the cleanest city in Ghana, and the Volta region, where there is no mining activity. We are delighted to have hosted you. We hope you have enjoyed your time. We are sure that this is just the beginning and we would like to see you again. And please, this university is going places, all right? And our focus is on health and development. And so on the behalf of university community and also on behalf of the organizers, Martin and his team, Chedodu and others, and our mentees, they put all this together. Joe, Sam, Joshua, and our MC here. He has a very interesting name, Paramount. Yes, that's his name. Is that your official name or is it a nickname? Wow. I mean, these guys have really done us proud. So we are very grateful to all of you. Thank you very much.
Let's clap for Prof properly. Thank you. So we take our vote of thanks from Dr. Gideon Chedodu. All right.
Thank you very much, Prof. Amuna. He's a professor of nutrition, and his interest is in capacity building, and he advises many international organizations around the world. And you can tell from how comprehensive his closing remarks are for our beautiful. We will bring you to come and say a word. All right, so he's thanked quite a number of people, but there are a few more that we need to also acknowledge. Because what began as a simple idea in April has traveled this journey, and here we are today. It's become a reality. And so we are really, really thankful. We want to see all the people who have contributed to make this a success. And the first go to, there's a cheap proverb that says that a coin chain adiefe, by sikani ade. So all the things that you desire to have, you cannot get them unless, it depends on your pocket. And so there's no way we could have had this event, this beautiful event, without the support of the donors. And so the first thanks will go to the Global Health Advocacy Incubator, and I think they deserve a round of applause for agreeing to fund all of this. And it's a lot of money. It looks simple. We have been here for just 4 hours, but the processes began 3 months ago. And we want to thank them and Stephen Atasigi for trusting us again to bring this to us. This is not the first. This is the second one we had 2 years ago. The next one has to go to our Vice Chancellor. Our Vice Chancellor. She supports every initiative that you bring to her. And I have to say that most of the people here that we have contributed to all that we've done here, they had very short notices. Some as short as 2 days. Professor Alexander Menu, I told him just 2 days ago that we want to see him here. And this is because of the very tight rope that we had to walk in terms of funding. The funders said they had a cap. They could only fund as many as 30 people. And I said, for 30, even the School of Public Health alone has more than 30 experts. And you want us to invite UDS, KNUST, UCC, University of Ghana, and all the international partners. I mean, there's no way 30 was enough for us. And so for most of our invited guests, we told them just a week or less than a week ago. And yet, here they are, they've made it to this place. So thank you all. You all deserve a big round of applause to all of you. I want to also thank the chair, Prof. Amuna. 2 days ago, he was told he was the chair, and here he is. He's captured everything well. And then the project implementer, Hope for Future Generations. Hope for Future Generation is headed by Cecilia Senu. Cecilia Senu and I go way back. We used to be classmates sometime, and I was a course rep, the president of the class. And so we've been friends for many years. And it's interesting that she speaks to Stephen, who used to be my mentee, and then both of them mentioned that, we think that if we send it to School of Public Health, they'll be able to implement this event. And so the School of Public Health, Fred N. Binka School of Public Health, all faculty at Fred N. Binka School of Public Health, the dean and all others, we want to thank you so much. And then to be able to pull this together, we needed the support of all the university, the schools. And so we formed subcommittees involving reps from all the schools. And so we had, for School of Medicine, Professor Gifty Ampofu. Yes, Gifty Ampofu, she's waving. For the School of Pharmacy, we had the dean, the incoming dean, Dr. Professor Cornelius Dodu and all the others. And all these professors, I am not a professor yet, but I managed to get them to work. And they worked so hard. But it got to a point where we realized that most of them were quite busy. And so you put a post on the page and the response will come after a week. And so one day I decided, no way. We've trained our alumni well enough to be able to handle this job. And so then came the technical team made up of Sam Joseph. Sam Joseph and the technical team, please come to the front. You deserve a big round of applause. So Sam Joseph, Joshua, Juliet, Ali, Umar, Paramount, F2G, all of you come to the front. So what we did was that we shared them amongst all the subcommittees, so 2 or 1 per subcommittee. And they were the coordinators, the secretaries. They had sleepless nights, meetings upon meetings. And all of you who received invitations, it didn't come from faculty, it came from our alumni. He hasn't even got a job yet. When did he complete? He just completed his master's in the School of Public Health, University of Ghana, a year ago. Do you have a certificate yet? Have you got it? Not yes. And they have been able to help us put this beautiful, beautiful ceremony together. And they deserve a round of applause. Let's clap for them as they go back. Yes. So I have a list of the faculty and APES committee members. Professor Martin Ayanori, Dean of the School of Business Studies. My goodness. My goodness. Applause. Yeah, I think he deserves the biggest round of applause. So he managed to get all the speakers, most of the speakers, Professor Justice Novignon, he got Abiru, his colleagues, mostly health economists. I am not one, so I didn't know them. But what the committee did was to actually look at the background of all academics in Ghana to see the kind of work they were doing, whether it was in the EPI space or health financing. And so Eduji here got a long list of about 200 faculty members across the country, but we managed to slow down. So for all the members, Dr. Joyce there, Head of Department of Epidemiology Department, Dr. Eric Osei, Dr. Mavis Kwabla, the moderators, Dr. Anthony Dondem, quietly sitting there. He's done a lot of job. He was the chair of one of the subcommittees, budget. So how much did it cost to organize all this? And then Dr. Kwame Ananga, Kwame Ananga, my own brother. And then we have Sylvester Yao Lokpo. You know that Yao was close to the mark, the Kwame. So Dr. Vivian Taki. So Dr. Vivian Taki, give us a wave. One of the moderators from School of Nursing and Midwifery. Professor Cornelius Dodu came with his whole team. So lots of faculty from School of Pharmacy were also here from the beginning. Professor Gifty Ampofo. And I see Prof. Zoto calling me. I don't know why. Maybe he has something to say. So let me put him on speaker. Prof, hello.
Boko. I thought you were still in Canada.
Okay, so I want to thank Prof. Zoto for all the encouragement and all that, and all of that. And finally, the last person that we need to commend is the consultant for this project. The Financing Immunization Advocacy Response, FAIR project. There was a consultant, Kube, who came, I should mention his name. Okay, I will mention that. So there was a consultant who put all this together, all the teams together. She's been engaging the parliamentary caucus on how to finance immunization, and then she engaged academia, and she met all of these professors. And so I want us to give it up. Maybe she has to come to the front. Wendy. Mrs. Wendy Abe, please come to the front. The consultant for this whole project. Thank you so much for working with us to bring this to fruition. Do you want to say anything? Oh. All right. So my work is done here. Thank you all. Professor Kube, he used to be with us. He's now with Somanya, the University in Somanya, Environmental Development. So thank you for coming. So, all right. Thank you. Thank you to everyone. All right. Prof. Soto, what do you want to say?
All right. So we take.
So we are going to have a more powerful event soon, AI conference. Very soon, all the experts in the world in AI will be coming to Ho, because we are beginning a conference here on AI in health. And it's going to happen in which month? In the month of August. Yes, right here on this campus. So for all our visitors who are coming from UDS and everywhere else, please make a day to come back again, because we will have the first one, the first in Africa. And we hope that it's going to be an annual event. And so the experts from around the world are going to be here. We have Professor Dumore, and we have our own Professor Alexa Menu, the director for the Institute of Health Research, who is driving this initiative. Thank you. All right.
Thank you. So we invite. Okay. So I'm sure lunch coupons have been shared to all of us. We make time and take our lunch on our way out. Thank you. Closing prayer.
Please, shall we rise up and pray? And so, Father, we thank you today for a successful event like this. We thank you for wisdom and insights shared. We pray that you continue to give us grace, that everything that we've had here will bring impact, a lasting one, to the health and well-being of the whole country. As we are living here, we pray for safety, that you send us back home safely. And when we get to our different destinations, we will not forget to give you all the praise. We thank you and we bless your name. In Jesus Christ have you prayed. Amen.